Can you hear me? Okay. All right. Never mind. And you're not going to? You're not going to do that? Okay. All right.
Yeah, this will slide here, and each one of those you can just tap as you want to go to it.
Okay.
Okay.
Wow. I'm having to do a lot of techie stuff. Just anywhere up here. So, all right. Good afternoon. Wow, what a crowd. And I'm glad you're all here. Welcome. Welcome to our Ginger's Hope, our diabetes education class. Stephen and I are just here to share a little bit about Ginger's Hope. Some of you have heard about it before, some of you have not. Please feel free, if you haven't had lunch, please help yourself. If you have, we'll pick up your stuff here in a little bit. We'll have snacks a little bit later this afternoon. We are right now we're trying to do this remotely to Phillipsburg. So we're welcoming several, like 20 people that are at Phillipsburg right now. So Ginger's Hope is super excited because we've been waiting a long time to get diabetes education to more rural communities in western Kansas. So we're excited to be able to do this. And if the remote works well, then we can maybe do it to more smaller communities next time. So I want to tell you a little bit about our story, the story of Ginger's Hope, how it came to be, what we've learned, and I guess where we're going and what we hope to do. Stephen is here. This is my husband. He has worked the whole Ginger's Hope, starting and working it with me, and we lived a lot of our diabetic life together. So we celebrate our 32nd anniversary this month. So we're thinking we've been together and lived this life a long time together. I'm going to tell some stories. The story of Ginger's Hope, Ginger's story, my sister Ginger. I can't really tell my story without telling hers. But my story is not necessarily the same story as Stephen has as a caregiver. So I'm going to tell you my story, and as he has something to share, he'll jump in. Because, like I said, they're not necessarily the same. Some of you I know are caregivers to diabetics, and it's kind of a little bit different role. Stephen might be here for a little bit if you had actually questions or something for him. So I know we're going to have to do a mic change after we get done, and so there might be a couple minutes in there for questions if you have them. So, Ginger's Hope. As you know, I've been diabetic for a very long time, 40-some years, 41 years this year. And for most of my diabetic life, I lived my life, I don't want to say it was a secret because it wasn't necessarily, I just didn't talk about it because I didn't want anybody to think I couldn't do something because I was a type 1 diabetic. Maybe I couldn't, I don't even know. I can't even give you an example. But in my brain, I thought everybody would think I was not capable of something because of it. So I just didn't say anything. A few years ago, Stephen and I started talking about how we could share our story, because here's what we found. Some people were interested in what we had to say. Some of our experiences, some of the things that we had learned, and we've lived our life, and we've had 2 children, and have lived a pretty normal life, and that all came from something that we've learned along the way, and we were hoping that we could figure out how to share that. And so we started talking about telling our stories. Well, my story, I can't really tell my story without telling Ginger's story. And Ginger's my sister, and I'll tell you her story. She was a diabetic, undiagnosed. She passed away at the age of 7 from diabetes, but it was undiagnosed. They did not know it when she passed away. So because of that, in the rest of all of my family, only I was diabetic, me and Ginger. And I missed her. I never knew her. I was born a long time after she passed away, but we didn't talk about her very much. There were not very many stories. It was very traumatic for my family. And so there just wasn't much there. And Stephen and I started dreaming about how we could share Ginger's story and make her story matter. She was here and lived and was, she had a lot to offer, and we just wanted to share that. Problem was we didn't know very much. And so before we did anything else, we went and talked to my mom, because my parents were so traumatized from that. We never talked about Ginger. And every time we did, they cried. And even Judy and Cindy, we just didn't talk about it because it was so hurtful to my family. And so, but we went and talked to my mom. We told her what we were wanting to do. And she was much older, and she had begun to anticipate seeing Ginger again because she was not thinking she was going to live very long. And she was okay with that. It was okay. We could talk about Ginger. So anyway, from that, we started sharing Ginger's story. Up on the screen is a picture of Ginger. She was cute. She was a cute little girl, long curls, blonde curls. She did dance. She did singing. Judy says very, very talented. She was, when you look at that picture, Judy told me that she looked fragile, but she was not. She was very capable of asking for what she wanted and willing to do it and get it. Judy also says she was very charming. That's how she could ask for what she wanted and get it. In the summer of 1960, Ginger was 7. She began feeling bad. This was her school picture that year. So it would have been in the fall before that. And so she started feeling bad. And my mom had taken her to the doctor. They diagnosed her with the virus and sent them home to get well. Well, later, I don't know if it was that day or the next day, or Ginger fell into a coma, and they took her to the hospital, and she died there later in the night. That was a huge trauma for my family. My family was not ever the same after that. But what I know now is that my family lived through that. Judy and Cindy, and you'll hear their stories later in my story because it matters. They learned some things from Ginger that would, save my life 21 years later. So Ginger passed away in July of 1960. My sister Terry was born the very next day after Ginger's funeral. And so there was a lot of emotions in my family. Like I said, it was pretty hard. There was a lot of very hard years there, but it set the scene to save my life later on. And so 9 years after Ginger passed away, I was born. I have this super cute picture of me. I'm not very good at tech and talking, so please bear with me. So anyway, I was born 9 years later, grew up. My childhood was normal. I can't say that there was anything extraordinary that happened, like I wasn't a terribly sick child or anything like that. As I grew up, I was 12 when I was diagnosed diabetic. So that summer, the summer before I was diagnosed, I went to stay with my sister Cindy, who lived in Woodward at the time. And I was so excited to go, because it was like my vacation. And, I like to go and play with her kids and do the stuff, but I didn't feel good. And I knew I didn't feel good. But I went. And when I got there, Cindy, I don't know if she was immediately concerned or as I'd been there for a few days, she became concerned, but she began to recognize the same things that they saw in Ginger 21 years earlier. So I know she called all the sisters and my mom I don't know that they called my mom right away because I don't know if they were ready to deal with that just yet. But anyway, I was there for a little bit. I can remember I felt so bad. And we would, anyway, I tried to play, I tried to do all this stuff. I just didn't feel good and couldn't do it. So Cindy and Gary packed us all up. We headed back to Ulysses. And my mom called Dr. Brewer, who was the person who diagnosed Ginger. That was the doctor that diagnosed Ginger 21 years earlier. And they made an appointment. That was on a Thursday night. We came home. Friday morning, I was at the hospital having lab work done. And on Friday morning, my blood sugar was 376. Now, isn't that odd? I can remember that exact number, but I can. And I also can remember exactly Dr. Brewer saying, he called me Miss Chrissy. Chrissy, we know what's wrong and we can fix you. You're going to feel better pretty soon. And I thought, for me, I'm like, okay, good, because I really did feel bad, and now outside of that room, I know my family was having a crisis. My mom was upset, my sisters were upset, everybody was troubled. I know that there was a lot of stuff going on and a lot of fear, and because Ginger had been diagnosed but then died because they hadn't diagnosed it early enough, and they couldn't fix it once they got to the hospital. So that was not the case with me, largely because my family knew and understood the symptoms. And so anyway, from the very beginning when I was diagnosed, I was told, diabetes it's chronic. You will always have it. There's no cure. You will never recover from this. You will always live with it. But it can be life-threatening, but it doesn't have to be. You can manage it. And you can live a good, healthy, long, healthy life, even as a diabetic. And I've heard that many, many times. That happened. I heard that for all of my life. And so, I think I was in the hospital for 2 weeks here, learning how to give shots, do stuff, do my blood sugars. Back then, right now I have a sensor now that tells me every minute what my blood sugars are. Back then, I used a glucose machine that I would put, it was this big. I put my drop of blood on a stick. I would set the timer. 5 minutes later, I washed it off and then checked it, then stuck it in the machine. I mean, it was a job. And so I learned how to do all that. When I left the hospital here, I had an appointment to see Dr. Guthrie in Wichita. And Dr. Guthrie would remain my doctor. He'd be my doctor till he retired. I don't remember when he retired. I know he passed away a couple years ago. But he was my doctor until he wasn't doing it anymore. And he was the pediatrician to my children when they were born, and was my diabetic doctor through all of that. And so I think it was a month maybe after I was diagnosed, we went to Wichita. Well, when we were there, I got sick. And I don't know, if you're diabetic, type 1 diabetic, type 2, when you're sick and throwing up and you're trying to manage your medication and your food, we were only a month in. And it was very scary, so we ended up at the hospital. And from that, we ended up at class. And we went to diabetic education class only a month after I was diagnosed, and that made all the difference for me and for my family. So as you sit here, just know that this is my heart, that we can bring these classes out here and everybody can learn and know and be able to function as good as I could and learn, take advantage of that. So, what I want, for Ginger's Hope, much of what we want to share is to be in contact with people early on, to know exactly that. While this might be life-threatening, it doesn't have to be. It's not a death sentence. You can live a long, healthy, happy life. Stephen and I met Stephen when I was in high school, and he joined my diabetic life. It was one of those things you're going to jump in, and he lives it just as much as I do, and our kids as well. Jamie and Jacob, they were a part of it. They know what I act like when my blood sugars are low, and they know to get the food and do this or do that, or you know that life as your family. As a diabetic, you need to know your family lives that with you. It's a huge thing. I can't tell you when I was pregnant how many times Stephen saved my life. You see memes on Facebook about how you save your life with a juice box. It was very much like that. A lot of times as we were having our children and living our life. And so I tell you all those stories because those stories are the stories that matter. And Ginger's Hope, from all that, Ginger's Hope, Stephen and I think we started our fund in the Grant County Community Foundation. As soon as we came up with our plan, what we were going to do, how we were going to tell the stories, and how we were going to try to make a difference, we went to Judy and Ken because we had no idea how to do 501c3, any of that stuff. We were just kind of like, we just don't know. But lucky for us, they did. They knew the stuff, and we got a fund set up in the Grant County Community Foundation in November of 2018. And we started doing fundraising and started going. I did talk to Judy and Ken first. My kids were all a part of the decision to start the fund. And my sisters, Judy and Cindy and Terry, and our cousin Linda in Pennsylvania have all been super instrumental in getting the whole organization up and going and running and able to do stuff like this. We have to do some fundraisers early so that we can do these things. We have the money to help and do stuff. So we've done that when, let me see if I can find I have this picture of my mom. We think she'd be super happy. It hasn't always been, like I said, we didn't talk about Ginger much. But by the time we started in 2018, she was good. So we've done a lot of stories. I've learned a lot. My family has healed a lot. My mom passed away in January of 2020. So she was alive when Ginger's Hope was created and got to be there for the very beginnings, the first fundraisers, those kind of things. So she was right in there doing her thing. After she passed away in 2020, that year we went ahead and got our own 501c3. So we still have a fund with Grant County Community Foundation, but we also have our own, we're established as our own charitable organization. So one of the things, Ginger's Hope, is set up. When we started this, we had to be very specific about what we wanted to do. And we wanted to raise awareness about diabetes, all kinds, but specifically these signs and symptoms of type 1. We want people to know and understand what that is and what that looks like, because we don't want any other families to have children who are misdiagnosed and end up passing away because we didn't recognize the signs and we didn't ask for the blood glucose, the blood sugar check when they were at the doctor or something. We want to raise awareness. We want people to know and understand all about diabetes, type 1, type 2, all the stuff, how you get it, what happens, and why. So we share this as much as we can. We raise awareness. The other thing we are trying to do and wanted to do from the very beginning was to help families financially, to purchase medication. I take insulin every day, and I would die if I didn't have it. I think we would all be shocked to know how many type 1 diabetics pass away every single day because they don't have the medication they need to live. I think we have some things working. I think there are some people working on that specific thing, but that's an issue. So that's one of the things we want people to not have to do. If we can help them financially get their medication, we want to. We also purchase supplies, can help buy supplies, syringes, testing strips, alcohol swabs if you need that. I'm trying to think of other supplies that you might need. Equipment, equipment's a big deal. And like I wear a pump and I wear sensors. And that has made my life so much easier. And we want that for so many people, especially sensor. If maybe you don't need a pump because you don't take insulin or whatever, but the sensor, that knowing what your blood sugar is all the time is so nice. You can eat your food and know, you can watch it on your sensor, know exactly what any particular food is doing to your blood sugar. It's super nice. And I know Julie will talk more about monitoring and blood sugars and stuff like that. But that equipment isn't cheap. It's very expensive. Oftentimes, insurance will pay for some of it, part of it, usually not all of it. So if Ginger's Hope can help with that financially, we try to. And the other part is education. And we're working super hard to do that. And look, we have a very nice class of people here, and we got lots of people in Phillipsburg as well. We're happy and excited about that. Our daughter Jamie, she is in Phillipsburg, so she's hosting the remote class in Phillipsburg with her. She's a nurse up there and is hosting that class there. So um, I think that's, as this week as I reflect about Ginger's Hope and the class was coming together. Last time we did this class in October, and we had 8 people. 8 people come. And honestly, we were kind of excited about 8 people because we didn't know what people would think. So the fact that we have 30 people here and we have 20 people in Phillipsburg, that's huge for us, and we're super excited about that. And so this week, as I was reflecting about Ginger's Hope, it occurred to me that a good work that God started in Ginger 70 years ago when she was born in 53 has come full circle now. And you can see that work flowing still through Ginger's Hope with all of my sisters, my cousin in Pennsylvania, our children, and all of our grandchildren. This is something that is important to all of us. And so, and we're very thankful. We're happy to be able to share our stories. Ginger's story matters. Her 7 years of life on this earth mattered. We learned some important stuff from her. And we want her story. Her story matters. My story matters. The story of Ginger's Hope is we're just hoping is going to make a difference for diabetics for many years. So, having said all of that, that's mostly our Ginger's Hope story. Do you have anything specific? You want
I'll get close here because she's wearing the microphone, but
I can take it off.
I'm not as talkative as my wife. I'll be brief. Um, Diabetes education and awareness is a big deal for us. Diabetes has changed our family, and before we were even born, and it's cost us dearly. It doesn't have to be that way. You can manage it. You can learn how to manage it and deal with it, and it's something you can live with, and you can have a relatively normal life, and there's no reason not to. I know our son a couple of years ago, not even a couple of years ago, he was talking to a coworker. She had a sick child.
There you go. It's stuck to me. So.
And anyway, he was talking to a coworker with a sick child, and the doctors were having a hard time figuring out what was going on. And our son said, "Well, these, I've heard this story before. Did they check her blood sugar? And the lady said no. And he said, well, maybe you should ask him. It doesn't cost much. It's quick. It's easy. And she did. She went back to the doctor, tested the child's blood sugar, and how high was it, Christy?
It was 546, I think.
Yeah, and so we he can't take credit for diagnosing the child, but he steered him in that direction, and that possibly it helped those people out, and that's what we want to do. We want to help. We hope you learn. We hope you gain something from this class. This is a good class. This is a good opportunity, and I hope nothing but the best for all of you. So I'm going to sign off there.
All right. Thank you. And then I'm going to, if you'll stay around just a couple minutes, I'm going to also introduce our educator, Julia. She's the one that's going to be doing the class. We're ready to move right on into the class, but we got to change out our mics and do all the stuff. So I have a couple minutes. Stephen will be here. I can help a little bit if you have questions, specifically caregiver questions, or and in Phillipsburg they can send those questions, Nathan, if they have them, and we can sure address some of that. So just in this couple minutes, if you need to go to the bathroom or throw away your lunch trays or whatever you need to do, we'll give us 5 minutes and we'll get right on into the class, okay? Yeah. Oh, yes. I should introduce Nathan Engelman. He is responsible for the remote class, being able to do the remote class up at Phillipsburg. And Ginger's Hope is super thankful for him because that's going to help so many and help us to reach so many more people if we can just continue on with that. So we're glad to be able to have such a nice place to do our class as well. So give us 5 minutes and then we will be back at you with the diabetes education, okay? Thank you, guys.
Mute that real quick. Just the mute on your box.
All right, so my name is Julia. So I'm a registered licensed dietitian and a certified diabetes care and education specialist. I've been working in diabetes care for about a decade now. And I have a really big passion, obviously, in working with people who live with the condition. And I work with those with type 1, type 2, and kind of just a plethora of conditions. So as you guys are probably aware, I come from Wichita, and this is the clinic that I work for, Wichita Diabetes and Endocrinology, and this is our team. And so the program that we put together today is actually an accredited program. So it's not something we just made up. It is something that we have curriculum based off of. And again, it's actually accredited through one of our organizations. So I just kind of say that because I don't want people to think, oh, this is our opinion. No, these are science, evidence-based practices and what we do know to be true for the care. With that said, there are opinions that I do have. And so if I have opinions that are not necessarily definitely known to be true, I'll let you know that. Like if this is kind of controversial or, there's differing opinions on this subject, I will let you know that and kind of what my opinion is. So as you guys also know, today is going to be a 3-hour session, and then tomorrow we'll do another 3-hour session. We've just found in the past that if we break it up, it's just sort of easier on people to kind of think through the material, maybe go over some of it later, have questions the next day, and it's not so draining in a full day format. So that's kind of how we structure the program. And so today we're really just going to focus on 2 main topics. We're going to talk about what exactly is diabetes. A lot of you have been living with the condition for probably quite some time, but it's always good to go back to the basics, to have that foundational knowledge. And once we establish that really good knowledge, then we can grow on top of that. And then it makes a lot more sense why some of these nutrition recommendations exist or why this recommendation exists. So we always start back at the basics, okay? And then we'll spend quite the majority of time talking about food. So who has questions about food today, right? Anybody have questions about food? That's why we spend a lot of time talking about food. It's sort of the one topic that people are very confused about. There's a lot of conflicting opinions on that subject. So hopefully my goal today is to really bring some clarity on that particular topic. So I also love for classes to be interactive. Like a lot of you, again, have been living with this condition for a long time. You have experience and knowledge that I think is worthwhile in a group setting. So like if you have something you want to share, please say it. If there's something that you think worked for you, that's one of the benefits of these group sessions is that people learn from each other. So definitely feel free to also say something that you think is helpful. Okay? Has anybody gone through diabetes education before? Yeah? Where'd you do it at, if you don't mind sharing? Oh, were you in my class last time? Okay. Well, then you had good education. Anybody else? Where? I know you came. Okay, so that's on a different level than me, I think. Dr. Guthrie is very worthy of education. Wonderful. Okay, so let's go through some of the basics. So what is diabetes? This is a metabolic condition. And basically what's happening is that your body is struggling to use its energy the way that it's supposed to. So I'm going to draw a little illustration on this concept because I find that makes more sense. So let me know if you guys can't see it or if the group over on your side can't see it. But I'm going to throw this over here. All right. So we have a blood vessel. We will have some glucose in that blood vessel, right? And then we have cells that feed off of this blood vessel. So this could be like a liver tissue cell, or it could be like a kidney cell or something like that, skeletal cell, etc. So a question for you guys. Do we always have sugar in the blood? Yes or no? We do, right? And we're supposed to, right? right? Because that's how we get our energy. And I want you to consider glucose that's flowing in the blood to be like quick cash. Like this is your quick energy supply that your body can tap into and use for energy, okay? Here's the problem. The problem is that this glucose, this energy, it can't go into a cell on its own. So I really want you to consider glucose to be like available energy, and it doesn't really turn into energy until it gets into a cell, and then it will provide energy. But again, it can't do that by itself, can it? So it needs something to help it get into a cell. So what's that something? Do you guys know? It's a hormone. Anybody? Thank you. So insulin. So this is how we're going to do it. Let's say that somebody has a perfect blood sugar of 100, okay, and that they're going to eat an apple. Oh, I need red for an apple. Or blueberries. Okay, so we got an apple. Quiz question. Is an apple carbohydrate? Yes. So when we eat that, what will that turn into? Sugar, right? And that's going to enter into our blood. So what's going to happen now? Oh, well, there's a lot of glucose now available. So this 100 is going to go up, and we're going to see blood sugar rise. This is a normal process, isn't it? Right? Our body is supposed to have more energy flooding into it when we eat food. That's completely normal. But we don't really want our blood sugar to stay high. So then what happens? Your body makes insulin, right? So then your body makes insulin. I'm going to make it like this I. And that is produced and goes into the blood. And insulin, some people refer to it like a key in simple terms. So it's sort of like the key to open up that cell door. And then what happens? Well, now our available energy can shift into a cell and then provide actual energy, okay? And once we have that insulin in the bloodstream, so that goes in, this one, this sugar molecule, this glucose goes into the cell, that one goes in, that one goes into that one, etc. And what happens to blood sugar? Goes down. And we were able to actually get energy. So that's normal physiology. That's the way it's supposed to happen, right? But in diabetes, a couple of things are problematic here. Number one, somebody might not be making insulin. So that's what's going on with Christy and what happened with Ginger, is that they could not make that hormone insulin. And so they could not have this metabolic process, and that resulted in what? Incredibly high blood sugar. And that, unfortunately, led to Ginger's death and then how Christy is managing it today. So that's number one. Now, some people can still make insulin, but what if they don't make enough? You know? Does that cause you to get as sick as maybe what happened with Ginger? No, but do you still have high blood sugar? Yes. So that's one thing. The other thing is what's called insulin resistance. And so we'll come back to this when we talk about insulin resistance, but that's kind of a whole separate issue, okay? So that's normal metabolism. I'll move this over. Okay. So if your bodies can't respond to that insulin, so that's again that insulin resistance, which we'll talk about more in depth, or we don't have enough insulin, then we have, of course, high blood sugar. So most of the food that we eat is going to give us energy, right? So food is good, isn't it? And, you know, food is more than just nutrition, isn't it? It's family, it's social, it's a dynamic topic. But in this context, obviously, when we eat food, we are going to get energy from that. And I just want to be clear, I'm going to use the terms blood glucose, blood sugar, but those are going to mean the same thing in today's discussion. So just to be clear on that. And as we already talked about, our glucose will rise when we eat, insulin is produced. And in case you don't know this, the organ that makes insulin is the pancreas, okay? where is the pancreas located? So the pancreas is right behind the stomach. And just from like a understanding of how the body works, it makes a ton of sense, right? Because you eat something and then food goes into your stomach. And what is your stomach doing? Well, it's actually starting to pulverize that food, and then it moves into the small intestine. So the pancreas is stimulated by that stomach pulverizing and moving, and it starts to know, oh, I need to release insulin, or I need to release this hormone, or this, enzyme, or whatever it is. So it makes a lot of sense that's where the pancreas is located. Okay, so I'm going to talk about this concept a little bit in depth. So I call this my simple but profound message. So I'm going to say it, and you're going to be like, well, yeah, I mean, that makes complete sense. But it's going to also make more sense, again, as we go on in today's discussion. So every time we eat a meal, as we've already learned, the pancreas releases a burst of insulin. But if we have a small meal, a small amount of insulin is produced. So a different amount, right? If we have a really, really big meal, well, guess what? More insulin is necessary to control that rise in blood sugar. So we're going to have a larger degree of insulin start floating through the blood. Does that make sense, guys? Y'all with me? Okay. Small meal, small burst, and a small rise in blood sugar. Large meal, large burst, and a large amount of insulin. Who kind of understood that concept? Has anybody ever been explained that concept before? Okay, so this is good to know. Who is on insulin? Anybody? Do you mind? Insulin. Okay. So we will talk about that, but it now makes maybe more sense that if you have a small amount of food, well, your insulin level should change based off of how much you're eating, right? If somebody has a higher amount of food, guess what? You have to change the amount of insulin you're taking, because that's how the body works too. So same concept. For those of you who are on oral medication, who's on oral? Oral medication, or maybe pre-diabetes, maybe trying to prevent diabetes from actually being diagnosed. What we're trying to do here is we're trying to minimize your pancreas being taxed out, okay? Think about it this way. You ready? Can you see your pancreas? Can you look inside yourself? No, but what can you see? You can see your skin. You can see your sugar, true, but you can see your skin, right? So this is another organ that we have. Actually, it's a very large organ that you can visibly see, right? So let's do it this way. Let's say we have this person who is not taking great care of their skin, and they're not wearing sunscreen, and they're going to the tanning beds, and they're, outside in the sun for hours on end. And they do this year after year after year. Well, what's going to happen to their skin? It's going to get dry, maybe get hard, maybe a little wrinkled. Yeah. What does it put them at risk for? Skin cancer. The pancreas is the same way. It's an organ that you can either protect and keep healthy, or we can push it really hard and it starts to lose its function. And then we get into the trouble of these conditions. Does that make sense, guys? Awesome. So I bring that up here because one of the therapies for people who are on oral medication, or again, if you have prediabetes, is that we're trying to minimize how much taxation is put on the pancreas by kind of reducing maybe there's large loads at one time. Yes, ma'am. Victoza is what's called a GLP-1. That's actually a medication, and we'll talk about that tomorrow. We talk. So it's a great question. That's a great question. So it is sort of like insulin in the sense that it's a hormone. So insulin's a hormone that you make and we're putting back into the body. This is the category of what's called GLP-1. That's a hormone that you make and we're putting that back into the body. But it doesn't do the same thing. It actually works more with the brain and appetite suppression, and then slowing the mobility of the GI tract. Yeah, I don't know. We'd have to look at that by a specific scenario. So, Yep. Yeah, great question. Okay, so one of the questions I get asked a lot is especially for people living with diabetes, is they say, okay, well, I know my blood sugar rises when I eat. When am I supposed to see it come back down? What's the appropriate time frame on that? So let's go back to, again, normal physiology. What we try to do in diabetes care is mimic how the body would normally function, right? So that's one of our ultimate goals. So if we look back at this person who doesn't have diabetes, they eat that apple, their blood sugar rises, insulin's produced, blood sugar comes down. We should see blood sugar normalize 1 to 2 hours after eating that carbohydrate source. Okay? So, question for y'all. Has anybody been told before by their physician or a friend, hey, you should check your blood sugar 2 hours after eating? Have you guys heard that before? Okay. Why is that? Because we're looking to see what is your number 2 hours after eating, and are you getting into the guidelines sort of like a person who doesn't have diabetes would do on their own. Does that make sense, guys? Awesome. So we'll go over what those numbers are. There's a couple organizations that push out guidelines for what blood sugars should be. So we're going to cover those, but I just want you to understand, what does that look like from a time frame, and why do we ask for people to check their blood sugar 2 hours after eating? As you guys might be aware, obviously, if we don't have that insulin available, and if you've seen it yourself on your own blood sugar, sometimes we're not into range 2 hours after eating. And so then we go back to what I call the therapies. The therapies. So let's talk about the therapies really quick. All right. So there are 3 therapies when it comes to managing and treating diabetes, okay? And 2 of them are actually primary. I'm going to let you guys answer, but I'm going to give you a hint on what the therapies are, okay? Who's watched a diabetes commercial for a medication, and at the very end of the commercial, they usually say, in conjunction with, thank you. Those are the primary treatments. Diet and exercise. Sorry, I heard that. I probably should have realized you guys might not have. So those are actually the 2 prime therapies for the treatment of type 2 diabetes. And then secondary or adjunct is medication. Now, sometimes I flip through slides, so I will do that here in a second. But let's do it this way. Who's gone to their doctor and their doctor has said, you know what, you need to eat better and lose weight? And you're like, well, that's really helpful. What does that mean, and what does that look like, right? So this is what I hear constantly in my own clinic, is that patients come to me and they're like, listen, I understand this concept, but I don't know what that means and what I'm supposed to do. So I'm going to bypass a few slides in case you guys want to follow me. Bear with me. Sort of at the very end. You don't have to, because we'll get back there again. You don't have to, but I try to be pretty concise. So I created this one slide, and basically I broke it down to some of the most simplistic messages I could think of to really address, hey, this is what we mean by diet and exercise. So we'll kind of cover this multiple times, actually. But from a diet aspect, we're saying, you know what? We know that maybe reducing calorie intake, perhaps looking at that portion size is beneficial. And so from a portion size aspect, does that make a little bit more sense why? When you go back to that simple but profound message that if we have higher portions, what does our body generally have to do? produce more insulin. And what are we trying to do to that organ? Are we trying to slather it with sunscreen and protect it? Yeah, and we don't want to push that organ as much as we need to. So that is why one of those recommendations exists. More plants. The evidence is strong that the more that we're consuming plants in its elemental form, so like, your vegetables. I am a nutritionist, guys. I have to tell you these things. Your fruits, these are incredibly beneficial, not only from a diabetes standpoint and a weight loss standpoint, but also to reduce cardiovascular risk and to reduce cancer risk and some of these other chronic conditions. So we're looking for, in case this is not actually on here, if you want to write this, you can. But we're looking for at least 5 fruits and vegetables a day. That's what we're looking for. And some people are like, whoa, oh my gosh, that's like a lot of fruits and vegetables. So just be clear, usually that means like half an apple, that's equivalent to a serving. Or it could be like a half a cup of cooked broccoli, that's a serving. So that's what we're looking for there. Beans are what I call the superstars of nutrition. So these are incredibly beneficial for so many reasons. I'm getting off topic because I'm getting excited. I need to wait until we get to the nutrition part. But anyway, and then fruit. All right, we talked about fruits, nuts and seeds. So we're looking for nuts and seeds like pretty much daily. We know there's a lot of good evidence on including that daily. And then whole grains. The other part there from a diet aspect is to avoid processed foods and restaurant foods as much as you can. What's a processed food, guys? Anybody want to take a stab at it? Maybe canned, depends. If it's like a canned chili, yeah. Lunch meat could be too, yeah.
Anything not on the outside of it.
Yes, I love that. Yeah, you got it. Generally, we consider processed items to be 5 ingredients or more. That's like one philosophy on it. But if it comes in a package, if it has a lot of ingredients in it, that's generally what we consider a processed item. Words you can't pronounce, you got it. Who knows what that is? Some chemistry experiment in this food. I actually call them food-like products. They're not food. Just because you can chew and swallow something does not necessarily make it food, does it? Okay. Yes.
She gets low blood sugars and then she eats and ends up too high and has high. She used to want to know how to solve that.
Okay, so that's going to be in tomorrow's class for a hypoglycemia treatment. Sorry. But we'll talk about that definitely tomorrow. Yep. Okay, so from a restaurant food standpoint, fast food standpoint, we're looking at 2 to 3 times a week at most. So anyway, that's what that looks like. Exercise, we got these specific guidelines too. Breaking up sedentary time every 30 minutes. You will see this. I might give you guys a break today, but definitely tomorrow, I set my timer and every 30 minutes we shake out the willies and move our body a little bit. So get ready for that tomorrow, okay? And then moderate exercise and doing resistance training. The reason why I bring this up, so let's kind of go back. I'm going to backtrack. So back here. So if we're looking at glucose numbers 2 hours after eating, or even pre-meal, and it's just not in range. So we're not meeting the guidelines blood sugar-wise. We go back to the drawing board. We go back to our therapies. And we say, okay, do we need to change something here to get into goal? Oh, do we need to incorporate something here to get into goal? Oh, you're doing everything you possibly can or within your reason. Okay, let's adjust medication. Does that make sense, guys? That's how we approach diabetes care and trying to get those numbers under control. All right. Okay. So this is just a little illustration I just wanted to point out. So if we do have excess blood glucose, I do want you to consider it being like syrup in your blood, right? So who's had high blood sugar and did you feel tired? Yes. Did you feel thirsty? Yes. All sluggish, all the things. So if we have excess amounts of glucose that's in the blood, it almost is making the blood literally like simple syrup. And then it becomes very gloopy. And are we getting available energy into the cell? No. So does that mean we're getting energy at all? Not really, not from glucose standpoint anyway. So it's just not the best thing for us, clearly. All right, so I just want you to consider that and how your blood sugar actually affects the viscosity of your blood itself. Okay, there are 3 main types of diabetes. So we're just gonna kind of traverse now into like what are the different types and what does that look like. And then there's this gray category called pre-diabetes. So type 1, as we've already talked about, is what Ginger had, what Christy lives with. So it is a lot more rare. Only about 5% of people who have diabetes are diagnosed with type 1. Generally, we did see people being diagnosed younger, so previously it was called juvenile diabetes, if you guys have heard that term before. Some people are kind of familiar with that term. And now we actually don't call it that. We call it type 1. So if you are not making insulin, your pancreas cannot produce insulin, you have type 1. And then type 2, you still make insulin to some capacity, you have type 2. So that's really how we classify them. And we do that now because guess what? People can actually develop type 1 at any point in their lifespan. So we do see, in fact, I'm actually doing research on this. Interesting, about 40% of people with type 1 are actually diagnosed later on in adulthood. So now we don't really say juvenile. All right. A lot of causes, a lot of speculation on what causes it. We sort of talked about this last time, but there's some seasonality connections. There's genetic connections. So you guys probably had some familial things going on there in your family. So kind of interesting. But yes, they have to take insulin to survive. Questions on type 1? We feel good about that? Understand? Yeah, we'll talk about that in a second. Did you have gestational?
No.
Oh.
But I have granddaughters.
Okay, yeah, it's becoming more common. Oh, wow. Yeah, we'll talk about that. Let's talk about that. We'll get there. So pre-diabetes, who was diagnosed with pre-diabetes? Anybody? Okay, so some people, yeah, I know that this is sort of lurking in the background. Okay, so what's happening there? Now let's get back to insulin resistance. Okay. So talking about insulin resistance, for those of you who live with diabetes, when you are stressed, what do you see your blood sugars do? They go up, don't they? Okay. If you're in pain, they go up, right? A lot of times insulin resistance is associated with hormones, okay? So if we have hormones that are being produced from stress, right? So epinephrine, cortisol. So these are hormones that are starting to flood the bloodstream from stress, from pain, etc. I really consider extra hormones like traffic. So here we go. So let's say we're stressed or we're in pain. Well, now we've got these hormones that are floating through the blood. And this is causing that traffic, and it makes it difficult for insulin to do its job efficiently. That's sort of the best way I like to explain insulin resistance. Okay, so that's understandable. So if we have these hormones and all of a sudden insulin can't do its job all that great and can't get to a cell and open the door, okay, I understand that resistance concept. Here's the problem. A lot of people have type 2 diabetes, right? So can we equate all those hormones from stress or pain or for whatever reason? No, probably not. What else is happening to cause these extra hormones floating through the blood? Anybody want to take a stab at that? Well, let's do it this way. So, what are we seeing as an epidemic in our country? Not pandemic, but obesity. Oh, that's true. Yes, that's true. Obesity. And so, what do we see correlated with that? Type 2 diabetes. Why? Because of this hormone causation. So usually, like historically, people thought about like adipose tissue, which is also the same word for fat tissue. It's just kind of the medical way of putting it. But fat tissue, we kind of thought, oh, well, that's just a place that stores energy. It's not like it does anything. Guess what? We were very wrong. It's a very dynamic organ that produces a lot of hormones. It makes a lot of hormones. So if you have all of this extra fat tissue that's very metabolically active and it produces a lot of hormones, what are we going to see? Insulin resistance, right? Okay. So if we have all this insulin resistance, is the body still making insulin? Yes. Do you think that because it has this traffic that it might be producing more to try to finally open the doors? Yeah, it does. And so all of a sudden, we do see an excess amount of insulin, an inappropriate amount of insulin flooding the blood to try to overcome this issue. You guys with me? Y'all tracking with me? What does that put on the pancreas? Does that put stress and taxation on that organ? Yes. Yes. It's just like somebody's going to the tanning bed. We're using that organ more excessively than we should. Okay? So how do we get rid of this, all this extra hormones? Well, this is why weight loss is so beneficial. So what we have this study, it's called the Diabetes Prevention Program. And basically, it was a clinically designed study, and it took people who had prediabetes, and they just found that if we can lose 5 to 7% of weight, so that of initial body weight, right? So that sort of changes based off of each people, each person, but that's roughly about 10 to 15 pounds, not 100, not 50, 10 to 15 pounds. We could see that the incidence of type 2 diabetes was decreased by 58% or 60% roughly. Okay, does that make sense now? Because if we can get some of this weight off, does that sort of clear the blood a little bit? Less traffic, and insulin can do its job more efficiently. And so, oh, I know. If I had it, I would tell you. Actually, I do a lot of weight counseling. I will say we are going to talk about weight actually in depth in several sections. We'll probably talk about it a little bit more tomorrow. I do speak a little bit. I actually love to talk about metabolism. I like to talk about different studies and what we do know about weight and weight maintenance. So we will address those, sort of. But can I cause 15 pounds be shed next year? I don't know if I can do that. I know. I'm going to come back with a potion next time. You'll buy it? Yes. Yes. So she is actually, she's developing type 1 diabetes. Yes. 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 So we call that 1.5, where we might even see that their pancreas can kind of release a little bit of insulin still, but she is turning into a type 1. Yes. She'll get there. Yeah. Yes. And that's generally what we see for our type 1s, especially in adulthood. is they think, oh, well, you're an adult, so you have type 2 diabetes. Let me try this oral medication and this oral medication. Wait, that doesn't work, and it's been 2 years, and we still have an A1C of 10. You need insulin. And then we realize, no, you're actually type 1. No. I've seen it as as old as in the 70s, and actually my oldest patient with type 1 that turned into type 1 was 82. So you can do it anytime, yes. Type 2s? Actually, I'm going to show a graph in just a second that's going to specifically answer that question. Mm-hmm. No. So those are, yeah, not for type 1, right, Christy? No. That what's happening is that's a great question. So type 1 is an autoimmune disorder. So what's happening is that body's immune system is actually attacking the cells of the pancreas that create insulin. And as of right now, there's not really many treatments to reverse it. It's definitely been a lot of discussion out there about trying to get it, but so far, no. That's a great question. I think somebody else had a question, right? Oh, okay. Oh, okay. Yep. Diabetes? We're going to talk about that. I have a graph. Actually, it's coming up, guys. It's coming up. It's a good one. But yes, so interesting that you guys had the same question. So that kind of goes back to we actually see about 40% of people who develop type 1 diabetes do so in their adulthood. So it's a lot more common than previously realized. Yeah. Okay, so anytime I talk about weight, I really I like to give some, I shouldn't say disclaimers, but I want to make some things clear and known. So first and foremost, I hope no one ever makes somebody feels bad about their weight or anybody feel like they're being judged about their weight. So I just like to make that pretty clear and known. Weight is a very complex issue, guys, and there's a lot of moving layers with why we have the weight issues in our country that we see today. So one of the ways that I sort of display this is just to kind of see how it's affecting the whole country. So this is new to the slides. I added this. But this is obesity trends among U.S. adults. We've got 1990, we've got 2000, we've got 2010, and you can see how the population at large is becoming more and more saturated with being considered obese. As we move into 2011, they changed the colors because it got a little harder. So they started notating differently what those saturation points look like. So currently, the most recent statistic is that 42.5% of our population is considered obese. That's almost 50. That's almost half. If you look at using the classification of overweight and obesity, we're looking at 70% plus of our country struggling with weight. So, do you think that was a choice? Do you think people choose to be overweight? No, they don't. And so this is where, again, we kind of talk about some of that understanding of why we struggle with weight. But just for you to see that correlation with diabetes, so kind of in similar time periods, we do see that the incidence of people being diagnosed with type 2 diabetes definitely goes up throughout the years too. So you again can see how that weight is primarily associated with the risk of developing type 2 diabetes. We do live in an environment that's not conducive for weight loss. I mean, isn't that shocking news to everybody, right? So we kind of know this. You know, our jobs tend to be not as manual as they once were. We have a million options to us at our fingertips, and it's convenient, right? And so we kind of look at this as the obesogenic environment. So we'll talk about this more in depth tomorrow, but I really like to talk about metabolism. But from a behavior change standpoint, we can look at maybe how we think and view food. I do that a lot in my counseling sessions, try to change people's perspectives on food, and maybe even understanding things like hunger cues, satiety cues, kind of really how they're, are we dealing with it from an emotional aspect? Like if you're a stress eater or a boredom eater, what do we need to do to cope in healthier ways? And then, individual activity and exactly what are we choosing. But then from another tier that's a little bit more complex and not necessarily in our control, is societal changes, influences, activity environments, and then food production. Did you know that your body does not like it when you lose weight? It doesn't like it. It fights against you. Does that like kind of speak to somebody? Yeah. Did you know that when somebody loses weight, their metabolism lowers? And your body creates more hormones to make you hungrier. And guess what? You also don't have as many hormones to try to keep you fuller longer. So your body literally fights against you. Why do you think your body fights against you? It doesn't like you. Yes, you got it. Absolutely. From way back and how we had to survive. Basically, it's never been to our, it's never been to our human advantage in the past to lose weight. It's always been what? To our advantage to keep weight on because of food scarcity, because of hunter-gatherer days, etc. So that's a big, big part of it. And again, we'll talk more about this tomorrow. Okay. Some people don't know this, and I already mentioned it, but again, our adipose tissue, which is what? Our fat tissue. Does it make hormones? Yep, a lot of them. And just make sure you guys can see that. Sorry if you can't. But these are some of the hormones that the body produces. I also want to talk a little bit about where fat lies in the body cavity. Okay, so let's chat about that for a second. Okay, I moved it back. I'm going to move it forward, sorry. Okay, I did not go to art school, all right? So I'm going to draw a body cavity. It's not going to be all that great. Bear with me. So, yeah, that's my body cavity. Okay. All right, so fat can actually reside kind of primarily in two places on the body. So the first place is what's called visceral, and I'm going to say V for short, so visceral cavity. And then we have this other place called subcutaneous. Can you see that okay? Are you fine? Okay, you got it? Okay. So it's important for us to have fat, isn't it? I mean, we need it to protect critical tissues and organs. We need it to actually give us heat. That's an important function. But if you were going to guess which place is it more damaging for fat to be in, which place would you guess? Visceral or subcutaneous? Visceral. Why? That's right. Right. So you have all your critical organs, right, in your visceral cavity. And what did we learn about fat tissue? It's metabolically active. And so therefore it can cause a lot of havoc if we have a high degree of this. It's a lot better for adipose tissue to be in the subcutaneous cavity. I like to bring this up because it goes into the metabolic syndrome and kind of like the metabolic maelstrom that we're seeing. And understanding that even if your weight doesn't change, can your health change? Yeah, it can. And we know that if we can get some of that fat in a better and appropriate space, even if weight doesn't change, we're going to see better metabolic outcomes. How do we know this? Sumo wrestlers, right? So sumo wrestlers are giant people, aren't they? They're like, what, 300 pounds or more? But they do not have the same conditions. They don't have diabetes. They don't have abnormal lipid panels. They have good blood pressure. Why is that? Even though they're huge. It's because they're so physically active that it's allowing that fat to be in the more appropriate space of the subcutaneous space and not in the visceral cavity. So if you were going to take like a CT scan of them, you would see that their visceral cavity is very clean and clear, but all of their fat is in the more appropriate place of the subcutaneous cavity. Make sense, guys? I was so glad you asked that question. I was waiting for it. So what did I say that they do? What do? They exercise. They train. They exercise. One of the tissues, or one of the hormones, I want you guys to circle this. If you have a pin, circle this. But do you see adiponectin over here? Okay, adiponectin. That's a really good hormone. That's a hormone we want, and we want high degrees of that hormone. How do we get that hormone? Exercise. So anytime that you're being physically active, you are actually causing more of this hormone to be released. And it's a good thing. And it's something that allows the fat to be appropriately signaled into that space. Okay? So what did we just learn? Is weight a choice necessarily? Do some of us really choose to be the weight we want to be at? Or do we have other influences around us that sometimes we're aware of and sometimes we're not? Right? If our weight doesn't change, can we change our health? Yes, we can. And that's what I want to empower you more than anything. Okay, so let's move over to type 2 diabetes. I'm going to move this back. So it's definitely the most common. 90% of people who have diabetes do have type 2. We've already learned we have insulin resistance or we've lost some of the ability to produce insulin. Usually it's diagnosed in adults. And I think that makes a lot of sense. We're going to take the example of skin again, right? So let's say somebody treats their skin super well, and they're constantly putting sunscreen on, and they're constantly wearing hats, and they're always staying in the shade. Well, even when they're 60, 70, 80 years old, will their skin still be the same as when they were 20? No. We can only do so much, right? And so, historically, we would see type 2 diabetes later in life, 60 and above, just because it's an organ that's sort of worn out. But now we're seeing it younger and younger. And now we're seeing it in teenagers and children. Type 2, not type 1. I mean, in my clinic currently, I have an 18-year-old who's taking insulin 4 times a day. He does not have type 1. He does not have type 1.5. He is type 2. And he's on insulin 4 shots a day at 18. That's not a good quality life. I've got a 14-year-old who has prediabetes and on that route. I've seen it as young as 6. If you can imagine that. Why is that happening? Why is our youth becoming more and more prone to developing type 2 diabetes? Absolutely. And go back to that simple but profound message. Do you remember? If we have a large load of carbohydrates at one time, what does your body have to do? Produce a ton of insulin. And if they're guzzling sodas and Gatorades and sugary beverages and sweets, what does their pancreas have to do? Try to catch up. And that is causing a lot of issues. Okay. Yes.
How did you discover that they had that? What was the telltale sign
Between type 1 and type 2?
that led you to believe that's what they were having issues?
Well, we can do lab work. So usually if we have somebody come in,
What I'm talking is
oh,
physical signs.
they're obese. Yeah.
Are they obese, or are they, do they have like mood swings? Do they get mad real easily? Do they?
You know what? I think what's happening is I think that's a great question. I think a lot of primary care physicians and pediatricians are aware of this issue. And so if you have I think there's like 2 criteria. Like if you have a family history of diabetes, and if you have like you're above the 95th percentile on the growth charts, they have rationale to check glucose to see, hey, do you have that condition, that underlying condition? Does that answer your question? I don't know if it did.
Well, it kind of did.
Kind of did? Yeah. I mean, because we're on the growth chart. Yeah. Because usually they're referred to us, like as an endocrinology clinic, and that we already know that they have diabetes coming to us, if that makes sense. Yeah.
Well, I didn't know. I mean, you said your son. So,
My son?
did you say your
I
son?
do have a son. He's 6 and 2. No. I've seen it as young as 6. Oh, yes, for type 2. Yeah.
Now, if the mother has gestational diabetes
Uh-huh.
and the baby's born at 13,
Yeah.
8, or whatever,
Yes.
does the baby stand a chance of getting diabetes?
A higher likelihood of developing type 2 and obesity in their lifetime. Yes. And it actually is coming, I promise. There is a good slide on that.
I have a question.
Yeah.
How come only one child gets diabetes, and say if there's 3 in the siblings, the other ones don't?
You know what? Yeah, that's a great question. I mean, I think we have to look at the underlining factors. So you could look at it from a genetic standpoint. You could look at it from different environmental factors. You can look at it from different behaviors. But sometimes it's not necessarily clear, to be honest. I mean, similar for type 1, there's still a lot of investigation on why it happens or why it doesn't. And we don't totally understand it all. Yeah. So, great question. I do use this platform to my advantage, and I like to kind of step on a pedestal, so allow me. But as adults, we have the responsibility to protect our youth. And if you have young children around you, if you're a grandparent or you're a parent, be very cautious and vigilant on what you're providing them. We have the responsibility on what we give and when we give it. They have the responsibility to choose from that what we provide. But if we're constantly giving them these things that are not good for their body, it doesn't matter what they complain or moan about. This is what we as responsible adults need to do. And I will step off, thank you. But it is definitely a concerning issue. So risk factors, you guys probably know some of the risk factors. Family history. So who has diabetes in your family, right? So again, if you think about it from the same aspect of your skin, although a lot of times it's easier to think about it like your eyes. So some people have poor eyesight, right, when they're young, and then they just always have it. And other people never need glasses in their entire life, do they? I needed glasses as soon as I was 5. So I was just not genetically hardwired to have great eyesight. And some of us just don't have maybe the best of pancreases. We just can't really see that. Does that make sense? And sometimes we see those traits being passed through a family as well. Of course, history of prediabetes, we kind of already talked about that. We've already talked about weight, history of gestational diabetes, and having a baby that weighed more than 9 pounds. So let's chat about that a little bit now, actually. Okay, let's do it this way. Let's do it this way. So let's say we have a mother that she's pregnant, right? And she does have gestational diabetes. But let's say her blood sugars are not controlled. So we know this is a condition she has, but we also know that she is running higher numbers than what's appropriate. Okay, you guys with me? Does the baby in her have higher blood sugars? Yes or no? No. No. The infant, the fetus in utero, doesn't. But what it does have is an abnormal amount of insulin. Because what's happening is that the high levels that the mother have is feeding into the infant, and the infant still knows how to regulate its own blood sugar. But it does what? It does that at the expense of its own pancreas. Does that make sense, guys? And when we have insulin present, we've kind of chatted about this, but what have we learned about insulin? What does it do? Its job is to push energy into cells. So we kind of consider insulin, it's a growth hormone. So if this little teeny tiny fetus has an abnormal amount of insulin so that it can push all that glucose appropriately so it has normal blood sugar, what's it going to do? Get bigger faster. Yes. Okay? So that poses a lot of risk to the mom, right? Because if you've got this infant that's growing at a rate higher than it should, what are we going to say? What's an OB going to say? Oh, I don't know if you want to give that baby vaginally, right? So you might want a C-section, and early at that. And then what happens? Well, all their organs might not be totally formed. And then, so now you will completely understand this. You ready? But let's say the baby's born. Baby's born, what's the biggest risk to that infant? Hypoglycemia. Because their body is still producing an abnormal amount of insulin. It's used to this environment of high blood sugar, and all of a sudden it comes out, well, that blood sugar is going to drop of that infant. Does that make sense, guys? So why does it put them at risk of developing diabetes later in life? Well, now you guys know the answer, don't you? Because has its pancreas already been worked at a very early age? Yes. And because we are born at a higher percentile than what we would like, we definitely know that weight is a chronic condition. And that if weight is not kept in check, if they're, anywhere from 0 to 3 years, those are very pivotal years. And if weight's not kept in check, and then after that, the likelihood of them developing obesity is incredibly high and keeping it high. So does that sort of make sense now? Yes?
On all three of my girls.
Mm-hmm.
All three of my girls, nobody weighed more than 9 and 10 pounds.
Uh-huh. Mm-hmm.
And they came a week, 2 weeks early.
Mm-hmm.
I had one at 4 pounds.
Mm-hmm.
They kept telling me, you're not diabetic. Your babies aren't big in that.
Yeah.
Longer to come out.
Yeah. No, I don't know. I mean, yeah, I can't say specifically why. That's a good question.
And my oldest daughter had 3 kids, and she's done it with all 3 of them. And hers falls in love.
Really? So that might be, other genetic reasons. Hard to say. Yeah.
But they tell you, you're not diabetic, because that baby's not big.
You're like, well, thanks, but not. Ugh.
Well, she's 54, 55 now.
Mm-hmm. Mm-hmm. Of course, if blood sugar is controlled during that pregnancy, we're not as likely to see that outcome, obviously. So we're really talking about like uncontrolled diabetes. So, yeah. Sure, yeah. Inactive lifestyle, poor diet. So we've sort of touched on that a little bit. And then even like maybe a race, ethnic background. So we do know that some people are more prone to developing some of these conditions. And there's kind of this theory behind it. It's called the thrifty gene hypothesis. And it goes back to what you kind of alluded to earlier, where you basically say, some of these cultures are really used and programmed to living off of nothing, basically, right? So if you have these cultures who have survived off of nothing for so long, they are much more hardwired to keep calories in than to excrete them. So then you place them into this environment of ubiquity. We're more likely to see weight go on them and have those conditions arise. So that's called the thrifty gene hypothesis. Definitely some interesting case studies out of that too. I'll just mention one. There's one culture, it's called the Pima Indians. Has anybody ever heard of them? Pima Indians? Okay. So they're in Arizona. They're actually close to Tucson. So they have the world's highest incidence of type 2 diabetes. So because of that, they're heavily researched. And we do know that there's another culture in South America who is genetically blood related. And that culture in South America does not have the rates of type 2 diabetes as we see as those living in Arizona. So we know, again, that environment is really causing the expression of type 2 diabetes. So, okay, here's my graph, guys. I've led up to it, this point. Okay, so this is showing the natural progression of type 2 diabetes. So just to kind of explain this a little bit, over here in blue, we have pre-diabetes. This dotted line is going to refer to when somebody might actually become diagnosed with diabetes. And then this is the time after that. Oh, that's right, it touched it. How do I forgot. Erase? I don't know. Okay, well, it's fine. It's fine. So this is the time after diagnosis. And here we have, the top one is referring to glucose. So we've got 50 to 350. In red, we have fasting glucose. Yellow is post-meal glucose. Down here, we have relative amount. And what that really refers to is how much the body's producing, okay? And so we've got insulin resistance, we've got insulin levels, and then we have pancreatic function. So that's what the lower two really refer to, okay? All right. So let's go back 15 years before somebody might actually be diagnosed with diabetes. And everything checks out great. Obviously, we have really good blood sugar control. Over here, we have a low amount of insulin resistance. We're making insulin and at an appropriate level. It's not like it's extreme or anything. And we have good pancreatic function, okay? So the statistic is that people gain 2 to 3 pounds per year. Which isn't maybe like a ton, but after 5 years, 10 years, 15 years, that adds up. And you all might kind of reflect back on like your own family or your friends and kind of see that sort of creep on people as they get older. Again, weight is complex, it's multifaceted, but that's the statistic. So what have we learned? As that weight comes on, we're going to see what? A higher degree of insulin resistance. And of course, that means that the pancreas has to produce more, I don't want to touch it, more insulin to try to keep blood sugar in check and at the expense of its function. Now, sometimes it does it too well. And in fact, some people develop what's called hypoglycemia before they're diagnosed with type 2 diabetes. It's maybe called reactive hypoglycemia. Has anybody had that issue before by chance? No? Okay. It happens to some people. It's hard to tell on this graph, but the lines actually get a little bit closer because insulin is pushing out so rapidly and so much that sometimes it does cause low blood sugars to occur. But what do we now see? We see that eventually the pancreas gets a little tired of doing this and it gives up. and it starts to reduce its ability to produce enough insulin, and now we have high blood sugar start to occur. Okay, it's a little hard to see on this graph on my screen, but it should be easier to see on your books. But you have this yellow period, right? So notate that, right? You've got the 0 to 10 years after the diagnosis, you have this yellow period. So what is that? That is where, going back to our therapies, diet and exercise is most critical and most helpful in reducing the progression. So who asked that question about reversing diabetes? Somebody over here, I think, right? Yes. So who's heard that too, right? You can reverse diabetes. Is that true or is that false? It's false. So when somebody is diagnosed with diabetes, we do carry that diagnosis. However, what is true is that through lifestyle efforts, we can slow or halt the progression to the point where medication is not needed. Okay? And why is that? Well, because generally speaking, people have a pretty good amount of pancreatic function left, and they still can make a decent supply of their own insulin. I didn't say this, but when somebody's diagnosed with type 2 diabetes, about 50% of their pancreatic function is gone at that point. So that's, again, why that first 10 years is most critical. After that 10 years, the likelihood that somebody needs medication is incredibly high because we've lost so much of their own functionality. Does that make sense, guys? Has anybody here know somebody who was diagnosed with diabetes, did something, and now they have great blood sugar? Does that happen to anybody, or a friend or a relative? Happened? Okay. Yeah, and that's actually probably from the stress and the pain of the surgery. Yes. Yes, so I will give you a real life example of this happening because it can happen. I actually know a nurse practitioner, he's retired at this point, and he was diagnosed with diabetes. And he was like, "What? Not me. I'm a health professional." And he was so mad at himself that he got to that place where he was diagnosed with type 2 diabetes. And he was like, "I'm going to walk this off." And he walked consistently and walked off his anger and walked off the weight. He actually lost about 100 pounds in that effort, and he does not take any medication. And when he was first diagnosed, he was on insulin 4 times a day. But he was a bit, does that make sense now, guys? He could get off that medication because he was so newly diagnosed. We knew that he still had a lot of his own functionality, and he took the steps and the measures to lose that weight and was able to do it. Does that make sense? Right. It will go. He still carries that diagnosis. That's a great question, but he's able to stay so active that he's appropriately using his glucose. But if he stopped, very much the possibility, absolutely. My understanding is he just did walking, but I'm sure he made dietary changes too. I just can't confirm that. Yeah, great question. Yes, ma'am. You know what? That is something that is not totally understood. And if anybody else knows something different, let me know, because I don't think it's well understood why, except for, because actually type 2 diabetes the blood sugars can resolve even a few days after the surgery. So it is a little complex, and I don't think we totally understand why that is. That's a great question. I might have to research tonight and come back to you tomorrow on that. See if I find something different. Okay, great. So if we have become diagnosed with diabetes, and if we're in that first 10 years, Is it possible for us to go off medication? Yes. Can we slow or halt the progression of the condition? Yes. Can you slow or halt the progression after 20 years? Yes. But the ability for you to go off medication is low. Does that make sense, guys? Okay, great. Great. So going over here, I think somebody asked me this question too. So if you have type 2 diabetes, is it possible for you to develop type 1? It is. Because sometimes people lose so much pancreatic function that we can then clinically define them as type 1. It's rare, but it does happen. So, all right, we're comfortable with that? Okay. We talked a lot about the pancreas, but honestly, looking at type 2 diabetes specifically, it is a multi-organ dysfunctional state. There is a lot of things at play here, not just the pancreas. We definitely know that the brain, there's missignaling in the brain. We know that the kidneys are maybe not filtering out glucose like it should. We know there's just, a lot of different possibilities and mechanisms here. I'm going to point out two. Let's talk about this one first. So this one has to do with hepatic glucose production. So basically what's happening is that, hold on, I'm going to step back for a second. So do you remember when I said that your blood sugar is quick cash in your body? Do y'all remember that? It's like quick cash, right? All right, so we know that. So how quick is quick cash? Let's say a dog is running after me and I got to survive this dog attack. I've got 5 minutes or less to use that quick cash. So you have savings accounts that your body has figured out how to store glucose so that you can tap into these reservoirs. Y'all with me? So where are these savings accounts? Your liver and your muscle. Those are your two big savings accounts. Okay? So one of the dysfunctions that happens in type 2 diabetes is that the liver can start to release the savings account of glucose when it's not supposed to. So let's see if this has happened to anybody before. Who's gone to bed at night, looked at your glucose, woke up the next morning, and it was higher than the night before? And you're like, what the heck? I'm just sleeping. I didn't eat. Why did it do that? It did that because your liver started to release that storage of glucose when it wasn't supposed to. So how do we prevent that from happening? Well, medication definitely. But from a diet aspect, if it's helpful, some people find if they have a small snack before bed, we're talking about 15 grams of carbohydrates. That's equivalent to like 4 crackers or a little handful of pretzels or half an apple. That's what that's equivalent to with a little bit of protein. So you could have like crackers and cheese, or you could have half an apple and peanut butter. Some people find that actually helps their blood sugars in the morning because by putting food into our system, it's saying, I got this, liver. You don't need to release extra glucose for me. It's all good. I got food in me. And it actually does help. Not for everybody, but it's worthy of a try if you see that happening. Okay? Okay. So that's one I want to talk about. The other one is decreased glucose uptake. So we've got these savings accounts. And I want you guys to repeat it back to me. Where are savings accounts? Liver and muscle. Great. So how much do we store in these savings accounts? You store the equivalent of 100 grams of carbohydrates in your liver. And you store the equivalent to 400 to 500 grams of carbohydrates in your muscles. That's a lot of carbohydrate. 400 to 500 grams of carbohydrate, sugar, in your muscles, and 100 grams in your liver. That's a lot, right? Here's the problem. Let's say that my savings accounts they're tapped out, right? Let's say that they're full. They're full. what's going to happen to all that extra sugar? It's going to stay in the blood, isn't it? Right? So if we're not activating these muscles, we're not tapping into that savings account. And we're going to see that there's not an appropriate uptake of glucose shuttled back into the muscle cells like it's supposed to. Does that make sense, guys? Go with me on that? Awesome. Okay, so that's, again, we're going to talk a lot about exercise tomorrow, but I just want to leave you with that little tidbit that, again, by activating our muscle cells, we are tapping into our reservoir, and we're able to, therefore, any extra sugar we have get shuttled appropriately back into our muscle cells. Okay?
So what should we eat for that? Protein or carbohydrate?
Preferably a protein and a carbohydrate source together. So like,
That will make your blood sugar lower in the morning.
it could make it lower or stable and not necessarily rise. Yeah. So, yeah. Is that good? Any more on that? Questions? So that's a whole different realm. That goes back to the question that they were asking earlier from our satellite area of hypoglycemia. So for hypoglycemia, just again, tidbit on this one, but we'll talk about it more in depth tomorrow. But you want to treat with just straight sugar. So that would be 15 grams of pure sugar, a tablespoon of sugar, brown sugar, syrup, honey, anything like that. It can also be a half a cup of juice or half a can of regular soda. It could be like the little fun size Skittles or gummy bears. Those are appropriate. If you've got the glucose tabs, 4 glucose tabs is 15 grams. Those are the things, we just want pure sugar at that point to get that blood glucose up. And then after it has recovered, you can have a small snack with carbohydrate and protein to then keep it stable. So it really does work. Okay, so we've already talked about gestational diabetes, but just to kind of go back to it for a second. So a lot of times we find that insulin resistance from the placenta. Doesn't that make sense now? Because the placenta is the one that's really producing all these extra hormones in the body. Of course, if we have women who are coming into their pregnancy overweight, well, we're going to have, double the whammy when it comes to those hormones. So generally we see gestational diabetes found in like the second or third trimester because as that placenta continues to grow, it is producing more and more hormones. So it's a little bit more common for us to see gestational diabetes being expressed in that second and third trimester. For mothers who actually are diagnosed with gestational diabetes, they have a 50 to 60% likelihood of developing type 2 diabetes in their lifetime. Because we do know, okay, well, if you're already battling with that at this point, then it's a little bit likely that we're going to see that later on in your life. But of course, through lifestyle interventions, we can definitely prevent that from happening too. I'm not going to talk about this very much at all, but there are different types of diabetes that kind of fall in these random categories. So your LADA is actually your 1.5. That's another medical term for 1.5. It's called LADA. But there's actually genetic reasons, or maybe cystic fibrosis, or if you've had a pancreas taken out. So there's other reasons we see diabetes. Okay, so let's talk a little bit about some statistics. So these are the most current statistics from 2020. Looks like about 10.5% of the US population has been diagnosed with diabetes, and a good majority is probably not diagnosed, right? Because a lot of people can live with type 2 diabetes and not necessarily know that they have it. This is an increase from the last statistics back from 2015. So we do see that's about 1% plus from the last time statistics were collected. 1 out of 3 adults actually have prediabetes. What do we think about that? I think that's a lot. Do we think that's a realistic number? Do you think that's an accurate number? It's probably higher than that. I would agree with you. I think I mean, now that COVID has come into the picture, what do we think about that, right? I mean, some people have actually had diabetes expressed just through COVID, getting COVID. We are seeing that in our clinic. And then some people have the COVID-15, where some people are gaining weight. You guys might even have seen it in our youth. There's actually been great articles in the New York Times about our youth being affected through COVID, and then the way that they've actually gained in that time frame. So it's kind of bleak. Does anybody want to join me in diabetes care? Come on, I'd love to have you. I think we're gonna need it. From a pre-diabetes standpoint, if you can kind of envision with me this iceberg. So above the water, that tip of the iceberg is what we know. Below the water is what we don't know and what we believe to be kind of lurking in the background. So I'm thrilled that I'm here and that Ginger's Hope exists and that, you know, you have this mission to really educate, because education is power. So, all right. We've already talked about the symptoms a little bit. Who's felt these before? Anybody? Oh, yeah. Okay. Any of them. Have you felt any of those symptoms before? Mm-hmm. Yes. So do you remember when I was talking about excess glucose, high blood sugar? What does that do to your actual physical blood? Turns it into syrup. So again, that makes you pretty tired. That makes you urinate a lot. A lot of people question the increased hunger. Has anybody felt that before? Like, I get really hungry and I don't understand why. Because are you actually getting energy into your body when you have high blood sugar? No. We just have available energy, but no energy is actually getting into a cell. So what does your body think? Oh, you need more energy. So I'm going to make you hungry. So you can start eating to get more energy. Does that make sense now? Yeah. Increased infections. If we've got a cut at the bottom of our foot, we've got thicker blood. It takes maybe a little bit more time for that blood to get down to that cut and for those white blood cells to fight off of those infections. And of course, what does bacteria like to feed off of? Sugar. So all of these kind of make sense. Okay. So let's talk about blood sugar now, like actual numbers. So what are the numbers and what should they be? Okay, some people ask me this. They say, you know what, can you just tell me what's normal? You know, what is blood sugar supposed to be anyway? So if somebody is fasting and has not eaten for quite some time, it is considered normal to be between 70 to 99. Personally, if I had a patient come in and they had a blood sugar fasting 95 or higher, like 99, 96, 97, 98, 99, that to me would be a little bit of a red flag, but that's technically normal. And then 1 to 2 hours after eating, we should see blood sugar be less than 140 after they consume food. So this is normal physiology. 1 to 2 hours after eating, it should be less than 140 blood sugar. And that's normal, what should be normal. But if you have diabetes,
Ask a question, what happens when you add age to that? Does that number go up?
it doesn't. That is a great question. It does not. However, the guidelines for like A1C and control do. So if somebody does have diabetes, there is like different philosophies on what their control should be. And we do look at other things like medical conditions, yeah, other issues. Yeah. Yeah, no, I totally believe you. We have some patients that we would be thrilled if their blood sugar was less than 200. Yeah. So I'll talk about that a little bit more in depth, but basically the way that you'll see. So the way that the some of our organizations say, they have there's two organizations that have different guidelines. So we have the American Diabetes Association. This happens to be the one that we follow most often. So they believe that fasting glucose should be 80 to 130. And they say, you know what, that's what we're looking for if you have diabetes. If you can get in that space, that's pretty good. if you are looking at your blood sugar 2 hours after eating, we are hoping for that value to be less than 180, and that's doing good. So if you check your blood sugar, 30 minutes after you eat, and that's 200, okay, that's fine. We really want to see how are you responding 2 hours later. Does that make sense?
Then should you be on medication if it's over the 130?
If it's over the 130, are you talking about for fasting?
Yeah, fasting.
So if it's over 130 for fasting, generally yes, because if we can't get well, you can go back to the therapies. So you could always say, hey, am I able to change diet or exercise or do something different? And then if you can do that and that helps, then maybe not. But if you're doing those things and you're still getting those numbers, then medication, yes. Yeah. Okay. Then we have the American Association of Clinical Endocrinologists. They're a little bit more aggressive in their guidelines, so it does sort of depend on what people want to do. Just for fun, like my own way that I handle this is I say, hey, if you are new to diabetes, you're on oral medications, you've got pretty good control right now, I would love for you to stick with these guidelines if you can. But if somebody's on insulin, generally ADA is the way to go. So endocrinologists, yes, so they're a physician that works in the medicine or works in the field of medicine that studies hormones. And insulin is a hormone. Yes.
So this looks like you just gave 3 different answers to the same question.
Oh, I did? Tell me how.
One says 70, one says 130, and one says 110. So we're fasting.
Yeah, so there's 2 organizations. So the first organization, ADA, they say that fasting can be between 80 to 130, and that's their goal.
Why don't they agree that it's more than?
I mean, why do people ever disagree? Okay, different philosophies. So AACE, they do say blood sugar or fasting can be less than 110, and that's what they would want to see. But they say, huh? Yes?
Readings and everything. Will they vary individually?
The readings? No, not generally, but they can vary. I mean, of course, they can vary with an individual. But
said here, like 70 to a certain number. If I have 70, I have sweat, blurred vision.
Yes.
And
Yes. Yeah.
That's fasting.
Doing good. Yeah. Yes, absolutely. So what you're talking about at that point is tolerance. That's what you're talking about. And so kind of back to tell me your name, sir. Amen? David. I don't know where I got amen. Okay. So David. So if David's blood sugar is generally in the 200s, for him to be within the normal range, maybe 90, that might not feel great because the tolerance is different. Yes. Now, can tolerance change? Absolutely. It just might take time. I put people on insulin pumps. That's actually my specialty. And so I see this often because when they go onto an insulin pump, generally their blood sugars do improve. And so it's not uncommon for some of my patients to flip over, maybe not feel the best, just because those numbers are so much better controlled. But it does take time. Yeah. Did that answer your question?
Thank
you. You're welcome. Okay. So ultimately, we're looking for an A1C of at least 7. So that's kind of the hope there. All right. So speaking of, what the heck is an A1C anyway? Does anybody know? Average for 3 months of what your blood sugar has been doing, right? So who's had an A1C done before? Yes? Okay, great. So let's go back to, we're going to go back here for a second, right? And we've got our glucose. I need more colors. We have to write that in our notes, Christy. I need more colors. Okay, so let's say that we've got now our blood red cells incorporated. So this is a little, here, I'm going to make them like ovals. right? So here's our red blood cells. Okay. And if somebody happens to have, well, let's do it this way. So in normal glucose, regular blood sugar, sugar's sticky, isn't it? So as that sugar is passing by that red blood cell, guess what? Some of it just happens to stick onto it. It's just normal. It's normal for sugar to stick onto a red blood cell. So here's this glucose, it's passing by, and it sticks onto it. And that's fine. But if we have more blood sugar available, well, what's going to happen to that red blood cell? I'm going to kind of blow it up. So let's pretend this one's coming down this way. That way we can see it better. So there's my red blood cell. And we've got our blood sugar of 100, so we've just maybe have a few on us, right? And now we have a blood sugar of 200. So more sugar is passing by this red blood cell. What's going to happen? Yes. So I want you to think like, oh, this bagel is turning into a powdered donut. That's what's happening. So we measure an A1C every 3 months. And why do we do that? Because what's happening is we're basically looking at the dead red blood cells to see how much sugar is coated over it. And the lifespan of a red blood cell is 3 months. So we're saying, oh, okay, well, you've actually, expired. Your time is done. And we can see how much is coated over you over the past 3 months. And that's telling us, on average, what your blood sugar has been running. Okay? So that's a great measure, isn't it? But there's some downsides to it. So let's do it this way. Let's say that I'm person A, and my blood sugar has had a lot more variance, so a lot more swings. So here we go. We've got like this high, this low, and this high, and this low, and this high, and this low. And I go to my doctor, and I take my A1C, and it's 7. And now I'm person B. And here's my blood sugar. It's just, kind of more steady, maybe a little higher than it should be, but it's more steady. And I go to my doctor, and it's an A1C of 7. Well, who's doing better? Steady. It's those swings that are so microvascularly damaging. So we have a different way that we're looking at it these days. I'm going to bypass because I'm talking about it. I'll go back. Sorry, guys. We're going to go to this. So has anybody heard of a glucose sensor? Christy mentioned it, but anybody wearing one? Seen them? You're wearing one? Yes, you are?
I'm wearing a sensor, but it doesn't read constantly.
Oh, okay, gotcha. But you're wearing a sensor. Is it the Libre? Yes. Libre 2? Okay. Yes, you're wearing Dexcom? Okay. Dexcom is kind of great. Can I steal your Libre? Do you mind? Awesome. Participation from the crowd. Okay, awesome. So now what we're doing in our clinic and a lot of endo clinics is we're basically putting on people on sensors, and we're saying, you know what? We can measure the amount of time that people are actually in range, And what's in range mean anyway? What does that look like? So in range is defined as 70 to 180. So how often are people in these numbers? And we have got measures for that. And this is important because I'm going to talk about it with our food too. So I'm going to move this over some more. So in range, our goal here is 70% or higher. So that's what we're looking for. It is appropriate for hypoglycemia to exist. It's appropriate. We understand that with blood sugar, anything can happen, can't it? And having a high and a low is just kind of part of the journey, isn't it? So, but we do have a measure where we say, you know what? This is what we're looking for. Anything more than that is concerning. And so we say, yes, if you're 4% less than 70, 4% of the time, or 1% severe, that's within limitations. Anything above 180, 25% of the time is what we're looking for. And then there's other targets here too. And then we're also looking at like, again, variation, like how often are people up and down and up and down and up and down. And so that's what those measures look like. And so, David, let's see. You didn't know I was going to do this. But if you have a sensor, one of the beauties of this, if you get Dexcom or Libre, and I won't share your information, is that you actually have the ability to look at this. You can go into your app or your device and see, what is my time in range? What does that look like? And again, these are the measurements that we're looking for. So it depends. If you're on commercial insurance, you are doing good. You're doing good. You're doing good. I mean, there's a little improvement, but
I'm more afraid of bugs than I am.
most people are. Most people are. It's not a good feeling.
It does bad things to me.
Yeah. So to answer your question, for commercial insurance, it does depend on policy. So I can't give you a strict answer on that. A lot of insurances tend to follow Medicare, and Medicare says if you're on insulin at least 3 times a day, you qualify for a sensor. So, yeah. No. You still have to be on insulin. The only thing that they did change. For one shot. Checking sugar. I knew that they took away the checking sugar. I don't know about the one shot. That's news to me, but things change all the time. So that would be awesome news, but I don't know about that.
I've actually had 2. This is my second.
Yes.
3 years
Yeah.
prior.
Yeah. Usually there was more Medicare hoops you had to go through at that point. Yes. Absolutely. I have a patient that doesn't even have diabetes and wears a sensor. Yes. You just have to pay for it out of pocket. Yeah.
The sensor is a little device like what David has.
Mm-hmm.
Allows it to know what your body is doing.
Yes.
Oh, like a patch. Oh.
Mm-hmm. Without insurance, for the Libre, which is more affordable, so I always cite Libre, it's about $75 a month. Mm-hmm. Mm-hmm. Mm-hmm.
I get 3 of these for $112, so that's for like 6 weeks.
Mm-hmm. Yeah, and it sounds like you get some insurance coverage for it. Not that much, but you get something probably. Yeah.
It depends because my regular pharmacy is where their medicine is always less, so I go there.
Mm-hmm.
But these are higher,
Mm-hmm.
so I go to the pharmacy here just for my sensors because down there is going to be like 70 for each sensor.
Mm-hmm.
Here it's about 40.
And you can go through distributors. So sometimes, distributors are a headache, but sometimes they can offer better prices because they have more in stock.
I'm not on Medicare. I'm not quite old enough yet, so. But
yeah.
When we tried to get it, it only cost us like $4,000 to do a bunch of stuff before you get it.
Mm-hmm.
And then you have to learn how to do it and all this.
learning to do it.
Oh yeah, they're user friendly. You don't have to.
Part is getting the 2 things to untwist.
Yeah.
Put on your arm. I do not break that. Other than that,
Well, I started out diabetic when I had that little pill roll. And then the pee on the little strip.
Mm-hmm. Mm-hmm. So going back to our therapies, so again, whether you're either doing finger sticks and you're looking at these goals, or you're wearing a sensor and you're going by these goals, so either or, We can always go back to therapies. And we can always say, okay, if we're not quite getting into the goal more times than not, what therapy or therapies do we need to change? Honestly, most people, what I see in our clinic, most people have lifestyle behaviors that could be modified to help get them into range generally. And obviously, that's what we're going to talk about next. As I sort of mentioned, quite often physicians just say, hey, you need to eat better, be more active, but what does that really mean? What does that really look like? So that's why I'm here today, to talk a lot about that specifically, and to give you that knowledge.
On this,
Mm-hmm.
it says avoid processed food and restaurant food.
Mm-hmm.
So we would never have to be able to go out to restaurants.
There are specific guidelines on it. Yeah. So eating out is recommended 2 to 3 times a week.
And then on exercise, include resistance, break up sedentary time, move every 30 minutes.
Yes, so everyone have your walking shoes on tomorrow. We're going to be doing that tomorrow. Mm-hmm. Yeah, I give you guys a break today. Yes.
All these ads, they have on different Facebook, different things like that.
Mm-hmm.
They all say no potatoes, and now they're saying no beans for sugar.
Yeah. Yeah. Let's talk about that in just a second. What was your question?
It's kind of a little bit of back, but it says note your A1C should be higher than 6.5 or greater. When I went to the doctor, she told me it couldn't be higher than a 5.6, and I was a 5.6 right on, and so she was telling me that I was pre-diabetic.
Mm-hmm. So did you say, what slide are you on again? Let's see, is it this?
It was the A1C 6.5.
Let me look at it really quickly. Okay, that one. So, yeah, I think you're talking about when somebody has diabetes. So this one. Oh, yeah, this is for the diagnosis of diabetes. But anything below that, we actually can term pre-diabetes. Mm-hmm. Yes. So I would agree with her thought process. Yes. Okay, guys, let's move over here. So we do refer to diabetes as a team sport. So we kind of say that because, as Christy mentioned, you are the individual with diabetes, but you have other people to support you. Caregivers, family, relatives, friends, your doctor, and then maybe nurses, or even somebody like me, like an educator. We say that because diabetes it's kind of different from other conditions in the sense that you're really in the control seat, right? You're really the one that's kind of driving the ship. And you can't necessarily say that's true for other conditions. So a good way to visualize this is, let's say, I really should have this, but let's say I have a birthday balloon. It's blown up, right? I've got this birthday balloon. It's red, it's pretty, and it's blown up, and I'm trying to bounce it and keep it just right. And I'm trying to do my life at the same time. And I'm trying to drive to work and bounce this balloon. And I'm trying to cook and bounce this balloon and take care of my kids and bounce this balloon, or take care of a loved one and bounce this balloon. And that's what living with diabetes feels like, right? It's this constant bouncing of the balloon to keep that blood sugar just right. And that is a totally different condition than maybe heart disease, where you just take your medication and see what your doctor says, right? Very different. You are the expert of your life. You are going to know what's going to work for you or not work for you. One of my goals today is to tell you a lot of the guidelines and the recommendations out there. And your job is to look at that list and say, you know what? That's the one I can do. That's the one I can do. Nobody's perfect. You can look at it and decide how you want to manage it and what makes sense to you in your life. Definitely. Okay, guys, who wants to take a break? You need to go to the bathroom, stand up for a second. Okay, let's take 5 minutes and then we're going to jump back into it. All right? Huh? Oh man, they've been brutal.
For the crew over there.
Am I stepping back?
No.
Oh.
But when somebody asks a question, could you repeat it?
Yes, I can do that.
Because I was trying to type them in, I could
Me
not
too.
keep up.
I'm typing in questions as fast as
I
I
could
can.
not type them in. And, yeah, so if you'll just quickly repeat and
Okay.
give the answer to it, they'll be able to keep up. So
Okay.
some of those that they weren't quite.
Ready.
And also, I'm kind of an idiot.
Why? What happened?
Okay, so I have this here.
And what happens?
Okay, so.
Oh, then I can do that.
So you can. I was gonna see real fast while we're on break here.
Yeah, can you erase those marks I made?
Yeah, I will. I was thinking that I could get you a blank slide that you could just write on.
I mean, that would be awesome.
I don't think I can without putting one in.
Oh, I see what you're saying.
Yeah. Because this will. That's right. It's right.
Gotcha.
Okay. So I can essentially go in and add some. I can add some blank slides in here, kind of every few slides where it's a blank one, and then you just have them available. Actually, no, I can't do that while we're live. So we'll have to. We can leave that
Yeah,
tomorrow.
yeah, that's fine.
Tomorrow.
Okay.
It will be okay. So that will be easier. It'll put it right up here.
Yeah, and that way.
It'll put it on here.
Okay.
And it'll be. I zoomed in on it. I made a screen.
It's hard for them to see it. Yeah.
They
Okay.
So tomorrow, there's more of that using tomorrow, some drawings and
I actually won't. No, I will. Yeah, I'll be drawing tomorrow.
Okay. Yeah.
And then I'll definitely need internet access tomorrow.
Okay.
As far as just like, there's just a few resources I like to show.
Yes. Okay. And actually, if we can, if you'll give those to me, I can put those in here as well. And
Okay.
they'll just be on here as well. You just we can either like you just show them where the resource is at.
Well, the first thing I show is actually a video, and the video is embedded in the second session, so it's actually it's on the slide. Yeah. Okay. And then otherwise, what else do I put up? Yeah, I'll just have to. I mean, if you have a second afterwards, I'll just have to.
Yeah, we can.
Or we can do it in the morning, whatever.
We better do it. We better do it today so I can make sure that we're set.
Okay.
And tomorrow we'll go a lot sooner because there were still. I got kicked out yesterday before I had everything ready.
You're fine.
And so, I was just sitting there thinking about halfway through. I was like, oh my gosh, my pencil is on the iPad right there. We can be drawing this all right here.
You know what? Can I actually make this? Can't you like
stand it up?
Yeah. Okay, good. That will help me too, I think. Okay, perfect.
Yeah, it won't go much lower than that, but it will come up higher. But I think that's about as.
Yeah, that's good. Okay, perfect.
Okay, we'll work with that.
Okay.
Yeah, tomorrow that'll be.
Okay. Do you have to turn that? How do you turn it back on? Do you just touch it?
Oh, here.
Oh, okay. Got. Wait. How do you erase those things?
Oh, up there.
Yeah. Okay.
Hey, I was just going to ask you. When I was diagnosed at 27.
Okay.
And so they had assumed type 2.
Mm-hmm.
But I had a doctor, one of many, that did a test.
Mm-hmm.
Is there a test that can prove that whether your
Yes.
pancreas is making? Okay.
Yes.
He did that test and said that I was type 1.
Oh.
But when that I wasn't producing any insulin.
Mm-hmm.
And I went on from medicine to insulin within like a month or two because it wasn't going down at all. But then I told another doctor later, I said, he asked me whether I was 1 or 2, and I said, I was told I was type 1 because they did this test. And he said, there isn't a test that.
Oh, there is.
and he said, because I was diagnosed at 27, that it had to be type 2. So
No.
so now when people ask me, I never know what to tell them because I was never.
No, for sure. Yeah, I mean,
I think I'm type 1.
It seems a bit more.
You do the same thing. It really doesn't matter.
Yeah, I mean, the only thing, I guess there's 2 reasons why it could matter. So the first reason would be for you, just to have like that empowerment. I think the other reason would be from an insurance standpoint. So especially if you're going on a Medicare in the next whatever years. Yeah, I mean, Medicare does look at type 1 differently than type 2. And so there are more coverage for different things that's available for type 1s than type 2. So that would be like just from an insurance standpoint, that'd be helpful too.
Do you have to have proof that you're one of the
for Medicare, yes. And so Medicare, like for an insulin pump, yes. For sensors, no. So it just kind of depends on what you want. Yeah, but it's called C-peptide, and you have to do it as fast. You have to do it while you're fasting too, and it's actually, I think, on the slide of type 1.
Yeah, and I had it done a long
Yeah,
time ago.
it seems a little bit more likely to me that you have type 1, just considering that you were 27 at the time and just the progression. But yeah, hard to say for sure without knowing what that test was.
Okay.
Yeah.
So I've got a question. So
Yeah.
I'm a school teacher and I got COVID and they put me on steroids.
Yes.
It went over 300. At what point is it dangerous, or does that depend on the person?
Yeah, great question. So it's not generally dangerous over 300 for type 2. It's dangerous for type 1. So they can develop what's called ketosis. They're more prone to that happening over above 300 because they don't make insulin.
That scared me to death.
Yeah, well, yeah.
It really scared me.
Yeah.
And then my doctor said 350. And somebody else said, I would go at 300. But my next question, antibiotics, do they have any effect on your blood sugar?
That's a really great question. And I think that's a very interesting question that I would say I would hypothesize yes, but I can't give you definitive proof on that. I can tell you that it does influence the risk of type 1. That we know.
When you take a heavy amount of antibiotics,
it can actually, well, because what happens is it changes the gut microbiota, and that inherently will actually change how energy is processed throughout the body. Anyway, it actually can influence glucose numbers, and there is good evidence to support that it increases risk of type 1.
Wow.
Yeah. So I would say the evidence is unclear, but I think that there is some proof that that's a possibility for how it affects blood sugar specifically. Are you heading out?
No.
Oh, it's cold? Oh, okay. Yeah, it is chilly. Okay. I was going to start less than that. Can I start in like a minute? I've got a lot to go through. Okay. Okay, we're going to get back to starting. So let's talk about food. Yay. As we start this section, I think it's important to kind of share with you my food philosophy. And again, it will kind of go into some of the guidelines. So this is my opinion. This is not evidence-based, my thoughts. But my opinion is that who are we as man to think we can make something greater than what the Lord provided for us? That's my opinion. So how we're really approaching diet is really through a dietary pattern. And what I mean by that is I'm looking at somebody's overall arching patterns and just hoping that they're meeting the guidelines 70% of the time. Do you guys remember when we looked at sensor guidelines and we looked at how often somebody should be in range? And we said what? We said, how often are we hoping for people to be in range? 70%. And what does that tell you? Does that tell you that nobody's perfect and that we don't expect 100% perfect glucose? No. Every person makes mistakes. Nobody's perfect. So what I'm saying to you is I'm just hoping that people are able to eat within the guidelines 70% of the time. That's my hope. And what I'm hoping is that people are eating the real and beautiful food that the Lord has provided for us. That's my opinion. So there tends to be this battle between carbohydrate and protein and fat, right? So who's kind of witnessed this battle playing out? Like, oh, you've got to eat low carb if you want to have good control and lose weight. Or, it's all about increasing your protein intake. Or, low fat is the way to go. You know what? I would say it's about the quality of your food intake more than anything. And that is what's really lost, unfortunately, in that messaging. So over the course of any day, week, month, year, etc., we're making these individual incremental choices on what we're consuming. And this is totaling up into our eating pattern. And again, nobody's going to eat perfect. I certainly don't. I don't expect you to. I'm just hoping that your dietary pattern reflects eating the guidelines 70% of the time. The other really integral message here is that all of our little choices add up. Okay? So who's raised kids before? You got your kids, you're raising your children, they're in front of you, and they look exactly the same as yesterday as they're going to look tomorrow. But when you look at pictures of them the year before, what do you say? My gosh, you've grown, right? You don't see these incremental changes. But what happens? Change occurs. And that's the other thing I want to press into you, is that we're not looking for complete change overnight. We're looking for 1% better tomorrow. Doable, right? Definitely doable. So let's go to what our guidelines state. So our guidelines state, we'll follow eating healthy pattern. You're like, okay, well what does that mean? So we'll talk about that. They're looking for nutrient-dense foods to reflect personal preferences. cultural traditions, and maybe even budget constraints. I have plenty of patients come to me and I'm like, hey, this is what we could do. And they're like, well, I don't like mushrooms. It's like, okay, that's a personal preference. What do you like? Focus on what you do like. Cultural traditions. I see patients come in and they are from Asia and they have diabetes, and their provider has said, well, you can't eat rice. Well, that's kind of a slap in the face. That's their identity. That's their culture. Oh, you're from Hispanic background and you can't eat tortillas anymore. What? That's my identity. Why would we take that away from somebody? Focus on nutrient-dense foods. And the big three. So the big three we're definitely going to talk about today in nutrition is added sugar, sodium, and saturated. Although to a lesser extent, so I'm going to kind of trans fat. These are the concerns in our food system, not the potato. There's nothing wrong with potatoes. I don't know about you guys, but I have personally heard of the Irish potato famine. I have not heard of the Irish diabetes epidemic. Okay? Did eating potatoes cause diabetes for the Irish individuals? No. What's causing diabetes in our culture? Do we fry them? Do we overconsume them? Yes. Yeah, I don't catch it. I don't. Yes. Really? All right. One of my little pet peeves is I have well-meaning patients come in and they're like, listen, I'm not supposed to eat carrots. Carrots are high in sugar. And I think, why are we not focusing on Doritos? Isn't that the problem? Not the carrots? That's the problem, right? So this is the big concern more than anything, is the quality of our food consumption, as well as what I consider the big three: added sugar, sodium, and saturated trans fat. And I'm going to give you specific guidelines on what those three should look like and how much we should try to keep it to in a day. Let's talk about a healthy pattern. So when we're talking about a healthy pattern, I envision somebody incorporating a fruit and or, so it could include both, it could just include one, a fruit and or a vegetable. So at every meal, there should be a vegetable and or a fruit. That is good practice. And if we're able to do that, even to a small degree, we'll be doing what? Meeting the recommendation of 5 fruits and vegetables a day. So give me an example. What can we do from breakfast that is going to incorporate a fruit and or a vegetable? Omelets with vegetables. Beautiful. What else? Oatmeal with fruit in it. Beautiful. What else? Does anybody go to McDonald's? Everyone here says no. Well, actually, do you guys have McDonald's here? Oh, okay. Anyway, so McDonald's, what do people get in breakfast? Or when they go there? The burritos or the McMuffins, right? It's kind of like the most popular items. Can you make that at home and it's still as delicious and nutritious? Yes. You can have a tortilla, you put in your eggs, you put in your avocado. Bonus points for salsa or pico. Extra bonus points if you put in, I don't know, a vegetable of some kind, which I know is weird, but those mushrooms. Throw them in there, hide them under the eggs and the cheese. If you do a McMuffin, I mean, you can definitely fry an egg, have a whole grain English muffin that you toasted at home. Again, you can put in spinach, cheese, and make your own. Does that take more time? Yeah, it does. What's the thing about convenience foods? It's less time. What is the dangers convenience foods. Health, all of those things. Exactly. So, there it comes at a cost. It's just maybe not seen right away.
Like a tortillas, would they make them where, because they're fat-free or whatever,
Yes.
whole grain,
Uh-huh.
that would be better over a flour tortilla?
Oh, that's a great question. And that is a question that we can apply in a plethora of ways. So, what you're referring to is what I call the gradations of food. So, let's talk about that. And you can apply that to oatmeal. You could apply that to cereal. You could apply that to different things. So, let's take that option. We'll run with that one. Okay. So, what do you think is like the best of the best of the best tortilla? Like, what's the gold standard of tortillas? Corn. Homemade corn. Okay. So you're like, that's not going to happen. I'm not going to make my own corn tortillas, sorry. All right, but that's the cream of the crop, okay? So that's known. What's for health wise? Yes, and that would be maybe traditional Hispanic food culture anyway. Okay, so like what's below that? Corn tortillas that you buy from the store? Sure. What's below that? Maybe your own homemade tortillas, which, again, maybe not all that realistic. Yes, ma'am. You can make them with canola oil, but yes, the traditional is with lard, but you can make them actually with canola oil or olive oil for that matter. I only know this because I make them all the time. But anyway, and I'm from San Antonio. So that gives me the rights, right? Okay, so that's mine. So let's say you make your own homemade tortillas. Okay, that's great to know, but that's also maybe not the most realistic thing. What's below that? Maybe a whole wheat brand, sure. You could also you can sometimes find brands that have corn and flour mixed together, so that it's not necessarily the mealy corn tortilla, which doesn't taste all the best, or it's not necessarily flour. So there are brands that like incorporate the both, and then you can kind of go down from there. So the low fat or low carb. Who's seen the low carb tortillas or the low carb anything? Okay. Or gluten free or whatever it is. So to me, those are in the category of food like products. Those are in the category of processed items. Those are what I call designer foods. Those are foods that companies have figured out how to grab your attention and your money, thinking, well, I know that you're looking to eat low carb, but carbs are not the problem. What's the problem? The quality of our food and the big three. And our healthy eating, our overall dietary patterns. Somebody can get a low carb tortilla and then that night go to a steakhouse. That doesn't make a ton of sense, right? Okay, I would rather, if I was going to choose a brand, like if I was going to choose a tortilla, I would try to just get one that's made of flour, water, oil, if you can find that. That would be the choice. Less ingredients, the better. If you want a recipe, let me know. Actually, I can tell you. You guys ready? It's 3 cups flour. White flour, whole wheat flour. You choose. Mix them together. I do all 3, depending. It's a tablespoon of baking powder. Baking powder? Yeah. A dash of salt. 1/3 cup oil, your choice. And 1 cup of warm water. And then just mix it together. I think I make this sound so easy, but there is a skill, huh?
People say you shouldn't have flour, anything that's white. You shouldn't have corn, because that's causing a lot of cancer. Because
Yeah.
eat it.
Yeah.
Eat the cows.
I'm confused why that makes corn bad for us, though, if the cows eat it and then we eat the cow. Oh, I think what you're saying is we're eating too much corn. That's probably what you're referring to.
I'm referring to no corn.
Right. So anyway, probably concerns about how much corn we're consuming in general. Gotcha. Anyway, yeah, there's nothing wrong with these things. It's a matter of how they're consumed, what portion size, and how are they basically created. Yeah. So I didn't really answer your question. The answer is that corn is inherently good for you. There's nothing wrong with corn. There's nothing wrong with flour. There's nothing wrong with bread. Jesus broke bread, right?
But should you use whole wheat, red, whole white?
So that right. So that goes back to the gradation question. So that goes back to that. So the answer is the gold standard is if you can have like homemade whole wheat bread, that's like the best of the best. Jesus did not break bread with Mrs. Baird's. Sorry. It was, like it was actual whole grain, like sourdough, like made from yeast, like actual bread. That's what he used. And that's what we should use. But is that realistic? Not always. And I get that. But I think it's important to understand the difference. Yes, if you can't get that awesome bread, then yeah, then the thing below it would be 100% whole wheat. And why is that better than white? Why is it better than white? What do we get in fiber? What else? Vitamins. Have you guys ever noticed in some of our refined products, it has like white flour enriched with thiamine, riboflavin, blah 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 blah, all these minerals? Have y'all noticed that? Guess why? Because they've stripped the kernels so much that all the vitamins have gone out, and that caused nutritional issues at one point. So then the government mandated that they put some of it back in. um, yes.
Which oil? Does that have anything to do with your sugar high or low?
No, not for sugar high or low. It doesn't really influence that a ton. I mean, maybe a little bit, not a ton. Yes. Sorry, you told me to do that. I don't know. Her question? Oil. The question was oil and if that is going to influence a high or a low. And the answer is generally not. Yeah. Yeah. But the type of oil makes a difference in our health. So what would be good types of oils? Great. What's another one? Not as much. The evidence is not as clear. Avocado, probably. Canola oil, excellent. Canola oil is probably one of the most superior oils that we have. It's just not as well, from like a study standpoint, it's not maybe as well seen. And why do we know that? Why do we know olive oil is so good? Why do we know that? Years and years and years of history of using it. Yes, the Mediterranean culture, the Spanish culture, that is their oil of choice. So the canola oil is probably just as good. It's just maybe not as well known just from like a observational standpoint. Does that make sense, guys?
Have you made refried beans?
I usually make black beans, but I don't usually refry them.
So if you did, what would you use? What kind of
Oil?
shortening, lard?
I would probably just do regular canola oil, honestly. I don't know. Maybe some butter. Oh,
Shortening or lard?
yes. Yes.
And you said you use what kind of oil?
Canola generally.
Is there a difference in the taste?
I don't think so. Yeah. I mean, if you use olive oil, you'll probably notice a fruity taste, but I don't think so. Yeah. And you're not having all that saturated fat, which we'll talk about. There's so much to talk about. Oh my gosh. Okay. So, so let's go back to the drawing board for a second. So, what did I say? What's good practice? If we include a fruit and or a vegetable in every meal, that is good practice. That is what we should be reaching for, striving for. What else did I say? Do I expect you to do this with every single meal? No, I'm hoping that you do this at least 70% of the time. Okay?
So is there one type of fruit that is better for diabetics?
Okay, that is going into a different realm. I love the question. Okay, I'm going to answer that question because I think a lot of people have that question. I'm going to sort of sidestep. Okay. So we've got calories, right? What gives us calories? What's our food made up out of? Protein is one. Carbohydrate and fats. Okay, so obviously we're going to focus on carbs. Why do we focus on carbs? And that influences blood sugar. Is it bad for blood sugar to rise when we eat carbohydrates? No, that's normal. But if we have a large load at one time and it's poor quality, is that going to hurt our body? Yes. Okay, so under carbs, if you don't know this, there's actually 3 subcategories under carbs, and that includes starch, sugar, and fiber. Okay, so this is what's under that branch. So to better answer your question, we have to kind of break it a bit further under sugar. And we're going to do natural sugar and added. Okay, which one did I say was part of the big 3? Added sugar. Guess what? We don't have evidence to support that natural sugar is harmful to human health. Doesn't that make sense? I mean, when was it ever bad for us to eat an apple? It's never been bad for us. Oh, okay. Yeah. Yes. It is from a plant, yes. So that is a different discussion, so we'll have to come back to that. Great question. Okay, so back to this. So we've got natural sugars, added sugars. Okay, so fruit is not bad for you. It never has been and never will be. But let's go back to this simple but profound message. So I'm going to give you a real life example. You ready? So my mom actually has prediabetes. I put a sensor on her, so we could kind of track and see what was doing. And things were going great. Everything looked beautiful. And then one day she called me because she's in San Antonio and I'm in Wichita. She called me. She was just like, Julia, my blood sugar is 197. And I was like, Mom, what did you do? She was like, well, I was eating this cantaloupe and it was so good and it was so ripe that I ate the whole thing. So is fruit bad for you? No. But what happened? She ate too much. And that just happened to be a ton of sugar at one time in her body. And that resulted in such a high glucose levels because she does have prediabetes. Make sense, guys? So to kind of answer your question, so just know that, but then small deviation from that is what we have what's called the glycemic index. Who's heard of the glycemic index? So what is that? So the glycemic index basically means if we have a person that eats pure sugar, half fast with their blood sugar rise, and then if we compare that to any other carbohydrate source, how would blood sugar be affected by that compared to this standard? Does that make sense, guys? So if we eat strawberries, how quickly would we see blood sugar rise compared to a pineapple? Okay, so the answer is watermelon, pineapple, very, very ripe fruit happens to be higher in the glycemic index. Dried fruit happens to be higher in the glycemic index. This is where it gets muddy and where people are like, I thought you told me sugar, fruit was fine. And the answer is yes, it's always good for you. It has vitamins, it has minerals, it has fiber, it has all these nutrients that we need to live. But we have to be mindful of how much at one time. That's really kind of, the crux of it. Yes.
So when you were asking about fruits with breakfast, would a glass of orange juice count? Or would that be a negative?
That would be a negative. So why would that be a negative?
No fiber.
No fiber. Okay, and catch this. Well, that's a great question. Catch this. You ready? Let's say I have 1 cup of juice. How many oranges is that equivalent to? 2. So let's time it. Here I am eating my oranges. I have to like pick it apart and like, peel all the fiber off and all the peel and stuff and then eat each orange. Here's my juice. Right? And again, to your point, somebody mentioned over here, we actually don't get that many vitamins from orange juice just because of the way it has been processed, especially if it's in a clear container, just FYI. So, yeah, great question. Yes, that would be, of course, the caveat, because if we have hypoglycemia, we do have to treat that appropriate, and juice would be appropriate at that time. Yeah, okay. Half a cup is usually sufficient. Yes. Okay, guys, so that sort of answer your question? Yeah, okay, awesome. You know what? I can provide a list for you. I actually do have an Excel spreadsheet on it. Also, in case you're interested, the University of Sydney, like Australia, is really into the glycemic index. They're kind of the ones that like created it. So, fun fact: all of their nutrition labels actually have a GI number on it because they're so into the glycemic index. But if you go to their website, University of Australia, the University of Sydney, they have a scoring system for all foods. Yeah. Yes, it's the University of Sydney. And they have like a search bar and you can type in foods, but you might find weird things because it's Australia. So, like, what is that? Okay. So grains. So grains should be whole grain most of the time, and we've already talked about why, haven't we? Right? We've talked about the fiber benefits. We've talked about the vitamin benefits and all of those things. But the guideline here is that half of our grains should be whole grain. So what does that mean for the other half? You can have white bread. Yes. Shocking. You can. It's fine. So we're just looking for you to choose grains, whole grains, more times than not, if you can, right? That's the hope there. Let's talk about that from a blood sugar standpoint. So if we were going to have okay. So if we're going to have white rice and brown rice, so here's my white, here's my brown. What would we anticipate to see on blood sugar consuming the white? A higher. Why? And you're going to eat more of it. Because it lacks the fiber. So we kind of understand that fundamentally, but just to be clear on this, your body cannot digest all the fiber you consume. It can't. So what does that mean? It means it has to literally pick apart the fiber it can digest and the ones it can. It's kind of like taking time to do that. So it takes time on sugar getting into the bloodstream, and we're going to see a softer rise and a softer fall compared to something that is refined. Okay? Awesome. Also good for weight reasons. So if anybody's ever had, same concept applies for cereal or like just high carbohydrate meals. Who's ever had Cheerios, because it's good for your cholesterol, and you're starving within 2 hours, right? Has that happened to anybody? Yes, that's because it's just carbohydrate. It's just going to go through you. You really should incorporate a protein and a fat in every meal to make a lasting effect. Yes. Very high in added sugar, yes. Huh? Incorporating a protein or fat. Cereal is just hard. Honestly, truth be told, it's just hard. I mean, I don't serve it to my kids. I don't eat cereal. I'll be really honest with you guys. If I do, I incorporate that within. You guys are thinking I'm so weird. I use plain Greek yogurt, and then we add like granola and nuts and berries on top of that because that's a better profile of carbohydrate, protein, and fat. But cereal is just hard, wicked hard on blood sugar, and just from. Mm-hmm. Usually it's still a very high carbohydrate source. And then especially if you incorporate milk, what does milk have in it? Carbs. So it's just kind of double whammy. Yeah. And I follow people's blood sugars all the time, especially when I start them on insulin pumps. So we have that discussion generally at one point, like, oh, what'd you do there? Oh, cereal. Let's talk about that. Okay. Dairy. Dairy is controversial for sure. Oh, yes. Okay, so oatmeal, great question. So yes-ish. So that goes back to the gradations. What's the gold standard of oatmeal? Steel cut, right? What's next? Just regular, like whole, like old fashioned, right? And then you've got instant, old fashioned. And then what? Then we start getting to the flavories. Yeah. And then you have like the flavors like peaches and cream. Yeah. So those are like bottom of the barrel type of oatmeals, right? So if somebody is going to eat that type of oatmeal and think they're doing good for their body, they are sorely wrong. But from that question, if I was going to serve oatmeal, I would incorporate a protein or fat in it. Our family does peanut butter. So we incorporate peanut butter in our oatmeal. That's how we do it. We like to stir in peanut butter and again, maybe a little dollop of yogurt. We actually make sauces. So we'll do like blueberries and put them on the stove with a little bit of water and just like boil it down and then top it on our oatmeal. It takes like 2 seconds. From the elevator? Okay. I don't know what the elevator is. Okay. You're going to have to enlighten me. Yeah. Oh, that's a controversial topic that I don't know if I want to touch. Really? Oh, okay. Yeah. So dairy is controversial. I'll be really honest with you. There is definitely some different opinions on what dairy, how much dairy should be included, what type, all these questions. But as of right now, the general answer is that if you can do like 2% milk, probably better. I don't really recommend skim milk because we're losing the fat in that product. And it is important for us to have fat in order for us to actually absorb vitamin D. And again, just from like a satiation standpoint, it's probably a good idea. Yogurt, I really recommend plain Greek yogurt or plain yogurt. Sorry, guys, I do. Less things added to it. And I would rather see patients or people put things into their own yogurt to what they personally like. You have more control than what the industry is going to do for you. A lot of those new no sugar added or zero yogurts, whatever they are, again, are full of sugar substitutes, which the evidence on that is not good. So I'd rather you have plain yogurt. Cheese, also another kind of controversial topic, but generally I go back to the quality of the cheese and again, how much are we consuming? Okay, sorry, I'm almost done with this slide. We'll move on, I promise. But protein foods, just from your knowledge, a seafood standpoint, so we're talking about fish, shrimp, whatever, mussels, all those things. So they actually recommend having marine animals 2 times a week. And there's a specific reason for that. It's okay if you don't like fish. Like I said, look at the guidelines and go, oh, I can do that one or not. So it's fine, but that is the recommendation. Why does that recommendation exist? What's so great about marine animals? The answer is the type of fat is included in them. So they have what's called omega-3 fatty acids. You guys heard of those before? DHA, EPA, all these things. So these are essential fatty acids. And what that means is your body does not make them, so you have to eat them for good body function. And omega-3 fatty acids, I'm not going to spend a ton of time on this, although I wish I could because it's so fascinating. But that makes a big impact, obviously, on our health. It's a better type of fatty acid. just for your knowledge, so then we have this other type called omega-6s. Okay, and omega-6s are a bit more pro-inflammatory, so FYI, like the thought is that there should be like 1 omega-3 fatty acid to 3 omega-6s, if you guys can kind of catch up with me on that, 1-to-3 ratio. And guess what the current US environment is? 1-to-20. So we clearly underconsume these very vital, essential fatty acids, and they're heavily found in marine animals. So that's why that guideline exists. You can get it in canned tuna, canned salmon. Pouches are fine, heavens. You know, however you want to cook fish. You know, from like a practical standpoint, if this helps at all, the way our family functions is I usually do fish on Sunday because I grocery shop on Sunday. I meal plan on Saturday, grocery shop on Sunday, and then we have fish on Sunday because I don't really want to have fish on Wednesday when I bought it on Sunday. So yeah, and that's what we do. And we'll do like fish tacos, or we'll do like salmon baked in little foil with pasta and vegetables. Anybody ever heard of salad niçoise? Do you guys know what that is? It's like a French salad. It's beautiful, but it usually incorporates fish and then green beans and potatoes and olives and tomatoes, and that's a Mediterranean style. That's great. But yes, so actually, yeah. So actually, algae does. So there's been some thoughts on algae. I know your options are getting better or worse. I don't know. That would be the rare case that maybe a supplementation could be beneficial, but it's, yeah, that's a question. That's a good question. So.
On TV, they've got a new commercial now. This kid is sitting watching TV and he's putting in his mouth, and what they are is fish skins that have been like crunched up.
I don't think we know.
It's good for the fish. It's good for the fish crunch, and it's good for you. Wouldn't that be disgusting?
Yeah, that's new to me as well. I don't know about that. Yes, so they're anti-inflammatory is the biggest benefit there. Another huge benefit. Oh, she asked. Yes, she asked, what is the benefit of omega-3s? Yeah, so they're anti-inflammatory. Huge benefit is they really reduce cardiovascular disease risk, which we have not talked about, but let's sort of talk about it because yeah. Okay, so how do we develop cardiovascular disease? Like, how does that even happen? What's going into the, Poor diet, yes, but what happens like physically in the body? Like from, if you're looking at a blood vessel, you're looking at an artery, plaque builds up. Plaque builds up. Okay, how does plaque build up? Where does that come from? Diet. Where does it come from? Saturated fat, cholesterol. That's why those are the big three, or one of the big three. Saturated fat specifically, definitely. But from an omega-3 standpoint, it is something that actually helps lower our LDL, which is the good cholesterol, the bad cholesterol. Bad. So it actually helps lower our LDL, and it actually helps increase our HDL. Which one's that one? Happy cholesterol? Yes. Healthy cholesterol? Yes. So that's a huge benefit there. Yeah. Okay, perfect. I think we'll move on at this point. You guys want to talk about eggs? Anybody want to talk about eggs? Yes. Okay. Yes. So, definitely controversy on eggs. You guys remember when everyone was like, "Don't eat eggs; they're so high in cholesterol." So there's more of a concern again on the saturated fat than anything. If you want to know, kind of the current guideline is like 4 eggs a week. I don't know. I think again that's a whole food. I think it's how you incorporate it, but I don't have any problem with eggs. If you guys want to have an egg in a day, no issue with that. Beans and peas, we are looking for that every day or at least 4 to 5 times a week. That's an important thing. Nuts and seeds every day too would be beneficial.
I have a question on that.
Yes.
My husband likes nuts.
Uh-huh.
But
Does it have salt in it? Sometimes the salt. Yeah. I mean, so how, I think the question, here's my back question would be, to what degree, and then what other benefits are we seeing? So you have that acute rise, but are we having other benefits on the backside? Does that make sense?
You like eat some at night, and then in the morning, blood sugar might get higher.
Okay, he might be overeating them, could be possible. Probable, maybe more than anything, but yeah. So the nutritional differences is about the same. There are maybe some superior edges, so let's say walnuts and almonds versus peanuts, but they all are inherently fine to consume. Because again, a whole food is going to be the thing to focus on. Yes, you can have yolk. There's no problem with that. I know. It's because it has cholesterol in it. So kind of the thought was, you're supposed to keep your cholesterol to like so many milligrams a day. And like the guide one was like 300, and one egg provided about 200. So they were like, oh gosh, well, if you consume eggs, that's an issue. What was more of the issue is that people were doing what? They were having eggs and bacon, and their egg was fried in the bacon grease, and then they went and had a hamburger for lunch, and then they had steak for dinner, right? So that was more of the issue than anything. Yeah. Great question. Okay, let's see, what does that really look like? Some people are like, great. What does that mean? And how does that look in a 24-hour period? So this person might have 2 slices of whole grain toast with eggs and a cup of fruit. Lunch could be chicken salad sandwich with baby carrots and an apple, and dinner could be salmon with grilled asparagus and roasted potatoes. Yes, potatoes. What about another day? Okay, how about some whole grain English muffin with peanut butter and banana? Lunch could be like a Greek chicken salad with olives and feta and baked chips. And dinner could be Mexican stuffed bell peppers and black beans on the side, as just some examples. What do you guys think? Okay? Doable? Good stuff? Good stuff. All right, so that's like, I'm telling you some of the guidelines. I've kind of told you some of my philosophies. Let's see what our organization says. So this is from the American Diabetes Association. They say for good health, carbohydrate intake should come from vegetables, fruits, whole grains, legumes, and dairy products, and should be focused over intake from other sources that do incorporate the big 3: added sugar, sodium, and saturated fat. There's really no one size fits all, so that definitely frustrates people. You do have to look at your own personal preferences. You have to look at your time, your schedule. You have to kind of decide what is feasible for you. From a realistic standpoint, in our family, what happens is on Saturday, I take a little bit of time to look over the next week's schedule. I mean, we have a 6-year-old, we have a 2-year-old. We don't have any family bias. I work, and I'm in my master's degree. My husband works, he's in the Guard. I mean, we have to be strategic, but make it work, right? And so we look at this schedule, and then we say, okay, this is what we're going to do here. This is what we're going to do here. This is what we're going to do here. What do we need to make that happen? And I usually prep a little bit on Sunday, knowing what that week looks like. That is just from a realistic standpoint, how that could look. That's just how it works for our family. I don't know if it helps you. So I think it's important to maintain the pleasure of eating. So quite often, I have patients come to me and they're like, listen, I'm supposed to lose weight, and I know I'm supposed to eat like grilled chicken and broccoli, but that's so boring. It's like, no, it doesn't have to look like that. Like, give me your favorite food. Let's change it to the point where it's still pleasurable, but it gives you the benefits you're looking for. Who likes nachos? Anybody like nachos? I love nachos. So good. So you take tortilla chips, you get your onion, you get your bell peppers, you get your zucchini, whatever vegetables you like, your mushrooms. You saute them down. You put them on top of your chips with some beans. Are we supposed to get beans more times than not? Yes. And we have not talked about why beans are so superior. Hopefully we'll get there. But we add some beans, you add some cheese, you have a little avocado, you bake it. That's a great meal. If you can incorporate a salad, bonus points to you. Take what you enjoy and you can modify it to make it something you still love. Respect your cultural identity. Have your tortilla. Just maybe 2 is needed. We had fajitas the other night, so we did speaking of, I keep doing Mexican. Again, I'm from San Antonio, so I think it's just like my nature, but maybe we'll do rice. How about we do rice? So if you wanted to do stir fry, that's a great way of doing it. You can have brown rice, white rice. Obviously, brown rice is superior, but if you want to do white rice, I'm not against that. And then if you incorporate like beef and broccoli stir fry and just chock full of your vegetables, that's a great meal. That's completely doable. Healthy eating is good for everyone. There's really no need to make 2 separate meals. I don't know if you guys have done that before or been around people who are like that. Slightly annoying. They're like, well, I have this preference. It's like, no, we all eat the same. Everybody should eat the same. And the same is true for young children. My kids get the exact same food as we make for ourselves. There's no substitutes. Take it or leave it. Healthy eating is a habit, and it may take a while to get used to, but we're just looking at small steps. So when I talked about this earlier, but what's the goal for tomorrow? 1% better tomorrow. And guess what? Do all of your little choices add up? Do they ultimately make a difference? Yes, they ultimately make a difference. So this is a great book in case you guys are interested in books. I have plenty of recommendations on different books. But this one is called Atomic Habits. The writer is named James Clear. This is an excerpt from his book. And he says, we do not rise to the level of our goals. We fall to the level of our systems. How true is that? How true is that we might have the goal to lose weight, but our system is broken, and we're not meal planning, and we're not thinking ahead, and we're not prepping, right? That's our system, and that's broken. So if that's broken, how could we ever reach that goal? Make sense, guys? Atomic Habits. Yes. Great book. Also, another one that's kind of on the same level is called the Compound Effect. If you guys want different books on that. You guys ever heard of the Compound Effect or Atomic Habits? Both of them are wonderful. Sometimes looking at your identity. So this kind of goes to the why question of everything, right? So why are you here, right? So what brought you here? What is your intrinsic motivation? What's your why? What's your why? Is it because you want to do what? You want to be healthier? Do you want to be there for your grandkids? Do you want to move more? Do you want to have less pain? What is your why? And once you identify that why, you're able to make movement forward. Case in point, I have a young kid right now. He is on the road to type 2 diabetes. He's come in with his mother a couple times, and he's a teenager, so he just sits there like, well, I don't know why I'm here. It's like, so we've had to really work on establishing why he is here and why he should care. And it's taken some effort in several sessions, but he's getting to the point of understanding his why so he can make some changes in his life. Okay, so let's move on a little bit. We're going to go, we already talked about this concept of calories, carbohydrates, protein, fat, and now again, fiber, sugar, starch, and then added sugar and natural sugars. Let me see. Okay. Okay, so moving over to carbohydrates specifically, we've already talked, I feel like almost in depth. Again, they're not bad. What do we have to be cautious of? We have to be cautious of what? An amount of one time. What is that amount? What are we supposed to be keeping it to, right? So in general, women should really probably have no more than 60 grams at one time, maybe 75 if you're a pretty active individual. But that's sort of like probably, I wouldn't really recommend more than that at one time. That might be harmful. For men, probably 75 to 90 grams of carbohydrates at one time is likely an appropriate amount. I don't recommend any more than 100 grams at one time for anybody. Uh-huh. Mm-hmm. And if some of, I have people who are like, 100 grams? Well, who eats that? Trust me, you do. Trust me, it is very common. So if you can kind of keep it to that, that's probably ideal. And then again, we're just worried about that load. So just to be clear, what are our carbohydrate sources? What is going to influence your blood sugar? Well, all of these things. Bagels, bread, tortillas, English muffins, buns, again, all the cereals, your grains, your pasta, your rice. And then you have what's called starchy vegetables. So if we go, let's envision that I'm holding broccoli. So here I have this broccoli. Does broccoli give you calories? It does. What's it made up out of? A protein? A fat? It's made up out of what? Carbohydrate. What? You're telling me that all vegetables are made out of carbohydrates? Yes. And guess what? It's the foundation for good health, incorporating vegetables, which are carbohydrate based. But what does broccoli have mostly? Fiber, sugar, or starch? Fiber. What did I also teach you guys about fiber? Do we digest all the fiber we consume? No. So it's very low in calories, very high in fiber, and it's pretty low in starch. With that said, we have some vegetables that are higher in starch, and we digest more of that carb. So that's where the potato comes in, or the sweet potato, or even some of our winter squashes, like butternut squash, acorn squash, which kind of makes sense, doesn't it now? Like there's more starch available in a winter squash than there is in a summer squash. It's designed. Corn, peas, beans. So these are not bad things to consume. Just realize that they have more starch available to them. How much? So if you were to have a half a cup of potatoes, like a half a cup of mashed potatoes, a half of a cup of corn, a half a cup of peas, that's going to be equivalent to 15 grams of carbohydrates. Yes.
Okay, so beans are on this list and they're also on the protein list.
Uh-huh. They have both, actually. That's one of the reasons that they're superstars. They actually contain both. Great question. So if we are trying to maybe do 60 grams for females, and we had a half a cup of beans or mashed potatoes or peas or corn, and that's equivalent to 15 grams. Do you now see that it's not inherently evil to consume beans? It's a very appropriate thing to consume. If we were to have 1 cup of beans, what does that give us? 30 grams, because a half a cup is 15. If we have 2 cups of beans, that's 60. And I don't really know many people who really want to consume 2 cups of beans in one setting. I don't know, maybe you do. But that would be an appropriate amount. Okay, as we've already talked about, all fruit is 100% carbohydrate. Nothing wrong with that. Yes, we do have the glycemic index. And yes, if we have a whole watermelon that we consume, that's probably problematic. Dairy is... Oh yeah, as the starch. So that's a source of carbohydrate in that aspect. Basically, 1 cup of milk is going to give you about 15 grams of carbohydrate. And of course, sweetened yogurt and plain yogurt, both of those will give you some kind of carbs. Snack foods, and of course, our sweet stuff. We've already talked a lot about this, but these are like the best of the best of things to consume. And so let's chat a little bit more about beans at this point. So why do I keep mentioning them? So why are they so good, beans? Well, let's start with cost. Are they expensive? No, they're super inexpensive. Let's talk about convenience. Are they in a can? Is it easy to open a can? Yeah. Could you cook them from scratch? Sure. But if you have a can, how hard is it to incorporate that within a meal? Generally not that hard. Can they be a little high in sodium? Sure. Can you find ones that have no salt added? Yes. Can you drain the beans and wash them off? Yes. Do they have a high amount of potassium, magnesium, iron, folate, you name it, in them? They do. So it's something that helps regulate blood pressure. And again, because it has a high degree of fiber in them, it's something that can keep you fuller longer. It does actually contain protein in it, and it's a carbohydrate. So that's sort of why we say, wow, this is kind of some of our superstars. So if you are not used to eating beans all that often, it's just maybe a good idea to incorporate them slowly or mix them in some of your dishes. Actually, any of them are good and superior, but if I was going to pick one, black would be superior over pinto just from a magnesium standpoint. They do have more magnesium in them. But all of them are so good, honestly. So like if you wanted to do pasta, this would be a quick and easy dinner at night, but you could definitely do like sausage and just cook up the sausage and then have pasta, roast vegetables or saute them or steam them, one of the three. Incorporate that with some white beans with some of the sausage. So see how I'm kind of like incorporating it, but also maybe keeping something that you enjoy. And then having a little bit of Parmesan, lemon juice. That would be a great meal. Okay, awesome. Okay, added sugars. So let's talk about one of the big three. So we don't have any guidelines on how much natural sugar people can consume. We've already talked about why. We don't have evidence to show that it's bad for people's health. What we do have is evidence to show that added sugar is harmful to people's health. So there's actual guidelines on that. You can see up here, but for women, it's about 30 grams a day. And men, it's 45 grams a day. So you're like, okay, well, wonderful. Actually, it's less for children too. But how do I know? Like, how do I know how much added sugar I'm consuming? Well, of course, if you're adding your own sugar, you can look at that. 1 tablespoon of any sugar is equivalent to 30 grams. No, I'm sorry, I lied, 15. I told you wrong, 15. 1 teaspoon is equivalent to 5 grams. Okay? So if you add it yourself, you can kind of do that math. But if you have a food label in front of you, they now have to tell you how much added sugar they put in their products. So look at this one. Here we have our friend, right? Our friend, the cereal. And we look at the serving size first, don't we, guys? Anytime we're looking at a food label, we look at the serving size first. Why do we look at a serving size first? It's usually less of what you want. Okay, because it's telling you this is how many, how much nutrients or nutrition you're getting in this amount of food. And sometimes packages are tricky, aren't they? And they have multiple servings in a package, even though it's packaged like a single serving. So just be aware of that. So you look at the serving size, and then let's track down to total carbohydrates. So do you see that total carbohydrates is bolded? And what? We have dietary fiber and total sugars not bolded and indented to the right under total carbohydrates. Because why? What are the 3 things that make up carbohydrates? Sugar, fiber, starch. Fun fact, they don't include starch on a food label. I don't know why. So if you think to yourself, well, I don't understand, 12 plus 3 does not equal 40. The remainder is starch. They're just not showing that on a food label. Okay, further down, now you can see it's actually telling you the amount of added sugar in a food product. So it's saying the total sugar is 12, and out of all of those sugars, all 12 are added. So you guys might notice differences. I've got a couple examples that we can kind of pass around if you want to. You can sort of see the differences on that. I'll just pass around a couple for the moment. Okay. All right. Sorry. Sorry to disappoint. So we have a half a cup of honey bunches of oats, and this is providing us 12 grams of added sugar. Let's go back to the drawing board. A half a cup, that's honestly not that much, guys, right? Here's our half a cup. That's 12 grams. How much should women get? 30. That's almost half of what women need in a day. From children, we're basically there, right? Okay, so that is how you can tell how much added sugar you're consuming on a food label and how much we are asking for people to stick to within a day. Questions? Is that helpful? Okay, awesome. So I kind of mentioned this already, but if we have time, okay. But we do want you to have a carbohydrate, a protein, and a fat in every meal. Do you guys want me to talk about the differences on blood glucose for carbohydrates, protein, and fat? Do you guys want me to talk about that or move on? Yes, no, maybe so. Do you guys want to know like the differences on digestion basically for carbohydrates, protein, and fat, or do you guys want me to move on? No? Move on. Okay. But we understand the point. We want you to have a carbohydrate, protein, and fat. With every meal, you're not going to have as large of spikes in blood glucose when you're able to do that. Moving over to protein. So you don't have to count it. Yes. Yes. Mm-hmm. Oh, you're saying you're eating cereal with like a sugar substitute? And you're asking, is that better than cereal plus sugar? Is that what you're saying? Oh, that's a tough one. Both of them are pretty evil. Which one is the lesser of the evils? Yes, that would be the way to go. But A or B, I would say right now, I guess B, but I would rather, or I'm sorry, I guess A, I'd rather you, I guess, have the sugar substitutes on the cereal, but it is controversial. That's definitely controversial. I don't know if I can give you a clear-cut answer on that. I would rather you move away from it altogether. Or like what she suggested, no sweetener. Okay. It is also a tolerance thing, right? Didn't we talk about tolerance? We talked about tolerance from an aspect of blood glucose. And what did we learn? If you have a blood sugar of 200 and you get down to 90, it might not feel so great. Guess what? If you're moving away from sugar, it might take time, but you can retrain your tolerance level. Okay. Protein. So you don't have to count protein. If you wanted to count protein, you could. It's just not necessary. If anything, we're just worried about the quality of the protein more than anything. So from quality standpoints, what is the best protein to eat? Lean things, you guys probably already know all of this. The chicken, the fish, lean pork, lean beef, etc. Your nuts, your beans are considered protein sources. We do want to avoid saturated fat as much as we can. And we are going to find saturated fat mainly in animal products. So if we can move away from some of these animal products, it is to your advantage. Sometimes I consider some of these meats to be like a flavoring additive or a side dish than the main dish. That might be a better way to treat them. Also controversial, I know. But we're concerned about saturated fat. So this is one of the other big threes. So how much saturated fat should we get in a day? And we've already talked about why we're concerned about it, didn't we? Because what does that, a high degree of saturated fat increases our risk of heart disease, right? What's the number one killer in America? Heart disease. Which does have saturated fat in it. I digress. No, I'm just kidding. For people living with diabetes, you are 2 to 3 times more likely to develop heart disease. So obviously this is a big concern. This is why I personally have a problem with low carb diets, because when people are consuming really low carb diets, what do they replace it with? Proteins, and not the best ones either. Sausage. Oh, I'm on Atkins. I can eat as much bacon as I want. Okay, well you're missing the point. You're missing the broad picture, right? So we already set it up here, but we're looking for 15 to maybe 20 grams of saturated fat a day is appropriate. So going back to our food label, this is a frozen pizza. If we have 1/4 of this pizza, this is going to give us 8 grams of saturated fat. What do we think? Expensive? I would call it expensive. You might notice over here, have y'all noticed the percentages? Like, what does those mean? So that has to do with a 2,000 calorie diet. So if you're going to consume a 2,000 calorie diet, these percentages equate to the recommendations. So they're basically saying that's 40% of what somebody's saturated fat intake should be. Does that make sense, guys? So there is kind of like this thought that if you keep it to 10% or less, it's usually better for you. So if you can get the saturated fat to be less than 10%, that's probably a good pick. And same thing is true for sodium. But this has a low amount of added sugars, doesn't it? So that's good. But not from other aspects either. So fat is your friend for sure. It's just a matter of what type of fat. We do need it. It's an essential nutrient. We've kind of talked about that, but it's almost like the beauty nutrient. It's really good for your hair. It's very good for your skin. It's important for nails. I mean, we definitely need fat in our life, but it's about that quality. So we're looking for more unsaturated fat, which would be termed monounsaturated, polyunsaturated. I highlighted or bolded the ones that are maybe a bit more prevalent in our understanding that it does help reduce disease risk. So polyunsaturated fat specifically, walnuts, flaxseed, fatty fish, those would be better sources of those types of fats than the soybean oil or corn oil, or et cetera. Yeah.
So, what about the all-natural peanut butter compared to just jar?
Yeah, I mean, so that's going back to the gradation. Yep, you got it. Yep. So best would be, of course, if you can get the natural peanut butter. Yeah, definitely. I'm going to give you all a little study on this. You ready? So who's heard of the Mediterranean diet? Anybody heard of that? Okay, great. So they actually did a great study in Spain, kind of showing the effects of what diet can do and reducing disease risk, specifically heart disease risk. And I like to talk about it because in this cohort of people, they had high risk to develop heart disease. So they were considered overweight or obese. They had type 2 diabetes, or they have already had a previous heart event. Okay, so these are individuals who could definitely have another heart event in the future. And they said, you know what, this is what we're going to do. We're going to put half of you on this like Mediterranean diet, and the other half, we want you to do like a really low fat diet. Okay? And so on this Mediterranean diet, they had to consume like 6 tablespoons of olive oil a day. So they had to have at least a good amount of olive oil every day. They had to have nuts every day. They had to have olives every day. They actually got a glass of red wine in the study every day. So this was what they did. They had to eat fish, and they had to avoid processed foods. So that was what they did. And then the low-fat diet, they just watched how many grams of fat they were consuming, okay? So big difference, because you're talking about like a high level of fat in this person's diet. It's just a better quality of fat. Y'all with me? So what happened? So what they found is that for these individuals doing the Mediterranean diet, it did reduce their chance of developing a heart event by 30%, which is as effective as a medication. So pretty cool. Plus, they enjoyed it. They didn't mind having their red wine and their, little snack of nuts in the day. That wasn't a problem. And they were able to participate in the study because they liked it. The low-fat individuals, they did not see that same level of outcome. Plus, a lot of them dropped out because it was really hard to maintain. So I think that is a good display of exactly what we're talking about, the overall quality. Okay, so we talked about saturated fat. We understand that. We haven't talked a ton about trans fat. Has anybody heard of trans fat before? What is trans fat? So trans fat is chemically altered. It is something that scientists kind of remade. And they did that because they thought it would actually reduce heart disease risk. And it would be a good replacement for saturated fat. So who remembers have margarine instead of butter? You guys ever remember that? So what did we find? We actually found that was 3 times worse for us than saturated fat intake. And it was that quick to actually cause heart disease risk. So now we actually have regulation on it, and it really can't be in our food supply. I mention this because it's a really good example of, again, why I have the philosophy that I have. I mean, who are we as man to think we can make something greater than what the Lord provided for us? Formula versus breast milk is another case study of that. And I think sugar substitutes is on the same path. I talk about this because I worry about designer foods like low carbohydrate or, diabetic friendly or whatever it is. These are products are designed. They're not actual foods. If you can, it would be wise to look at partially hydrogenated oil. That is a type of trans fat that you can sometimes still find on nutrition labels. And guess where we really find trans fat at? Fast food. It is very heavy in the fast food industry. Some products have 1 to 3 grams of trans fat in an individual item, like a hamburger, if you will. And really, some experts only recommend 1 to 2 grams per year. So that just kind of shows you the difference. That's what some people think. So going back to a healthy pattern, what does that look like? Not skipping breakfast. That would be part of a healthy pattern. Incorporating a fruit and or a vegetable with every meal. Choosing whole grains more times than not. Planning out meals. Making a grocery list. Cooking at home often. Eating out occasionally. Choosing lower or low sodium foods. Choosing leaner meats. And avoid eating late at night, if you can. So those are some of the pretty clear, hopefully clear guidelines. And what's my expectation? Are we trying to do 1% better tomorrow? And do I expect people to do all these things 100% of the time? No, that's unrealistic. I do hope that you guys can do this at least 70% of the time. Last one of the big 3, sodium. So this one is definitely controversial. There's many differing opinions on how much sodium people should consume in a day. I think that it's actually not really well known yet. But as of right now, the thought is probably 2,300 milligrams or less a day is a good idea. Again, kind of back to that trick. If you can do 10% or less of the daily value, that's likely a better sodium choice for you. So this would be a good example of that. We've got the Chef Boyardee. This is definitely a processed item and a food-like product. Serving size 1 cup, and then this sodium is 33% of the daily value. So pretty high in the daily value. Okay, is that helpful, guys? Okay, if you're going to go out to eat, you can generally pull up restaurant menus online. So if you wanted to take a harder look at what exactly they're giving you in a restaurant, obviously the chain restaurants will be more available than local restaurants. But this is a good example. So back to McDonald's. So here we go. We've got the Big Mac. This is how many calories it is. Okay, fine. This is how much fat it is. Okay, fine. This is how much saturated fat it is. 10 grams. Now we know, don't we? We understand that we're supposed to, oh, I forgot to write my sodium on here. We're trying to keep it to maybe 15 to 20 in a day. So now do you understand? It says the daily value is 50%. Do you see that, guys? Okay. And what does it also have? Trans fat. 1.5 grams. And again, some health experts believe we should only be consuming 1 to 2 per year. Look at the sodium. We've got 43% of the daily value, so quite high on that. And they do not show us the sugar, so hard to say how much added sugar is in product. But it does tell you what? It does tell you how much carbs we're consuming in that sandwich. And the sandwich here is going to give us 45 grams. Now, if we're going back to the concept of watching the load at one time, purely from a load question, is that an appropriate amount for women to consume or men? Yeah, 45 is totally fine. So when people come to me, watch this, guys. When people come to me and they say, I went to McDonald's and I'm eating a low-carb diet and I ate the hamburger, but I took off the buns. Are they not missing the point? What? Yeah, no, that did not help you. It didn't. So, okay, we are all on the same page. Yay. So just be aware. So too high of fat can actually raise blood sugar. So that would be maybe back to this question over here about the nuts. Potentially that could be happening. I don't know. I think it's a question of how much too. And if it's salted, that can make a difference. But again, with just carbs, we have that high rise, that high fall. And too high fat can actually elongate the digestion of the carbohydrates. And some people actually experience high blood sugar for hours after they consume something that's high in fat. Does that speak to anybody? Yeah, definitely. So in our allotted time, which we don't have a ton, do you guys want to try to do some carb counting practice, or do you want to do more, like we can talk about sugar substitutes, or do y'all want to do a little carb practice? Thoughts, opinions? What do we want? Yes. Yes. Yeah, so that's a great question. So you can do the plate method, which I don't think I have a sample up here. Well, I can kind of show it. There's materials on that table that really displays the plate method. But what she's referring to is if you take your plate, half of it can be really dedicated to vegetables, specifically non-starchy, and then 1/4 can be dedicated to a carbohydrate source, and then 1/4 can be dedicated to a protein source. And so do I need to repeat that for the satellite group? Is that good to do that again? Yeah, so she asked about the plate method. And so the plate method is 1/2 of the plate dedicated to non-carbohydrate sources. So your lettuce, your broccoli, your Brussels sprouts, your green beans, your eggplant, cauliflower, whatever. And then 1/4 can be dedicated to a carbohydrate source. So maybe that's 1 cup of rice, 1 cup of pasta. It can be, bread. And then another 1/4 can be dedicated to a protein. So whether that's a pork chop or a chicken or salmon or something like that. So that is definitely one approach. And it's a great approach. I think the only sort of issue I have with that is then we start to neglect some of this cultural food. So again, like mixed dishes, it just gets muddied, and you can still have beautiful food even if it's mixed dish, but it is a great approach too. Does that make sense, guys? Like if you could have lasagna, how does lasagna fit within the plate method? But you can have great lasagna. I make lasagna. You can have, again, vegetables that you roast, or you can either saute down. Sometimes I do spinach. Sometimes I make pesto. We're getting into the summer months. Pesto is definitely a good thing to consume. It's usually basil or parsley with nuts. Great flavoring additive, and then I just layer that on top of like the ricotta and the marinara, and then pasta. So, or like the lasagna pasta, and then you just cut a portion, and then you serve that with a salad. So that would be an example of how to do that. Does that make sense, guys? Okay, awesome. Great question. Do you guys want to do some carb counting a little bit? Sugar substitutes? Sugar substitutes? Okay, let's do that. Yes, but I'm also slightly crazy. So I'm slightly crazy. Yeah. I actually make a bunch, and then I freeze it in cubes, so that way it's easy to like put into the meals moving forward. Yeah. Yeah, so traditionally pesto, yes, pesto. Did you ask how to make it, or did you ask how to make it? No? Okay. You can do, generally it's basil, but basil is really expensive. So either you grow your own basil, or I just incorporate basil and parsley because parsley is less expensive. And then traditionally it's pine nuts, but I'd use walnuts instead, also for cost reasons, but yeah. And garlic, and then Parmesan cheese, yeah, lemon juice. That's kind of it, If you want to put a little red pepper flake for a zing, you can do that. Yeah, full disclaimer, guys, I grew up in a home that relied on processed food. I mean, I grew up eating Sonic and ramen. Like, I grew up in my snack when I got home from school was ramen soup. I grew up on the Lipton containers, the styrofoam ones. I grew up on Pop-Tarts. I grew up on frozen nuggets. I grew up on Sonic. I named a cat Sprite, okay? Because that was my drink of choice as a kid. True story. But when I became aware of what food was doing to me and doing to our society, I slowly and incrementally made these changes. It didn't happen overnight, and it didn't even fully happen over the course of a year. It was a journey. But I do make a lot of things myself because I understand and believe in it. So, sugar substitutes. Sugar substitutes, so definitely controversial. They do fall within the category of what's called GRAS. GRAS is generally recognized as safe. So this is what the FDA has actually labeled it as, is generally recognized as safe. So sugar substitutes are under this classification. There's been some outrage on, this sugar substitute causes cancer. Have you guys ever heard of those thoughts before? So truthfully, those clinical studies that showed cancer forming was in rats or mice, so not humans, which is fair. But also it was in a crazy amount of these sugar substitutes. I mean, 100 times more than what people would typically consume. So there's that too. That's why they're under the title of GRAS. With that said, they're generally safe, but there is some negative light on them. So I'll tell you what we kind of believe right now. So we do believe that it changes people's tolerance to sweetness. Fun fact for you, sugar substitutes are 500 to 1,000 times sweeter than regular sugar. And how can they do that? They can create this molecule, it's a derivative off of sugar, and they can put a little bit in, but you get this super, super intense sweet taste. And so the thought is that, back to the tolerance thought, right? So that tolerance discussion is that if people are used to this very, very, very sweet taste, it changes their tolerance to sweetness in general. And so there's a thought that perhaps people who have a sweet tooth start to develop a sweet thing because of that. I don't know if that speaks to anybody. I've had other patients who are like, oh, yeah, that's 100% me. I've been using sugar substitutes for 10 years. That's what's happening to me. So what's the philosophy? Probably the biggest one and probably the most compelling is that we have clear evidence that it is changing the composition of what's called the microbiome. So anybody know what the microbiome is, or have we heard of this? The gut bacteria. You guys heard of that before? All this bacteria that's like living in you. So there's actually more gut bacteria than there are of human cells, by a factor of 10. There's a lot of them. And so if you've got like this colony of bacteria that's living in you, do you think that the health and state of this bacteria makes a difference on the health and state of you? Sure does. Absolutely does. And we have clear evidence, unbiased, not supported or funded by these companies that are producing sugar substitutes, independent studies that are showing, yes, this is actually changing the composition of your gut bacteria, the ratios, the quality, the types. That makes a big difference in how you metabolize energy and your blood glucose. So there is definitely some like maybe a dark side to it that we are still exploring. So I don't know if that helped at all. I will say from a stevia, it is extracted from a plant. So if I was going to pick out of any of them, probably stevia and Splenda would be the ones that I would probably choose. Splenda. So if I was going to choose one, some people use monk fruit because it's maybe a little bit more natural too and still gives like a very sweet taste. Or you can incorporate sugar just within moderation. Kind of another like thought to that is if you're a person who really enjoys like cakes or brownies or cookies or whatever, it's okay to eat them, just make them. If you are making them, how often are you going to eat them? How often are you going to make them? How often are you going to spend the time? And I'm not talking about the box brownies, guys. I'm talking about you get your egg, you get your butter, you get your flour. I mean, you do the whole thing. So if you do that, how often are you actually going to consume brownies? See, that's the system. Because brownies are so easily accessible today, aren't they? You can just go to the grocery store, they're there. But what I'm talking about is that it's not bad to eat them. It's just don't make them so available. You know, like it's okay to be tempted. It's okay. But you have to realize how can we get out of that temptation and how can we make our system better? Yeah, agave nectar is a different one. Yeah, I'm not opposed to that either. It's supposed to have a lower glycemic index profile is the thought on that. Yeah. Okay, I think we're kind of out of time. Are we good? Or Splenda. Those would be a little bit more, I don't know, maybe natural. Yeah. Monk fruit is another option to explore. I'm not opposed to that. That would be within the categories of sugar substitutes. That's considered generally recognized as safe. Yeah. Okay, guys, any other questions? The last thing I will leave you with is what's called SMART goals. So in my class that I do in Wichita, we usually develop SMART goals. You guys might have heard of this before, but they're called SMART because it's specific, it's measurable, it's attainable, it's realistic, it's time bound. Essentially, it's trying to put more detail into what somebody's goal is, and the more that we're putting detail into it, the more that we can probably achieve that. Most of my patients are able to achieve their goals once we sit down and we really talk about it. And that's actually how I approach my individual counseling as well. As we do a lot of this SMART goals. Not only that, we talk about what's called habit stacking. Anybody ever heard of habit stacking? If you're trying to develop a new behavior like exercise, stack it on top of an already existing behavior, right? So if you enjoy watching TV in the evening, why don't you do a little bit of exercise while you're watching TV? Because you already have that established behavior. We talk about making things obvious. If you're trying to eat better and you're buying fresh fruits and vegetables, but you put them in the refrigerator and then it's in the bottom drawer and you forget about it, and then a week later you're like, oh yeah, there was carrots in there. I forgot about that. make it obvious. Like put a bowl. Who has a bowl of fruit on their counter at their home, right? There you go. That is a way to make it obvious for you to eat better. So think about that when you're making these SMART goals and how to make it obvious, how to maybe stack it on top of something already existing. And then last thing, make an incentive for yourself. Make yourself a goal that has a reward attached to it. Maybe it's getting your nails done. Maybe it's going to the golf course. Maybe it's getting something small off of Etsy you've been looking for. I don't know. But always attach an incentive. All right. With that said, I think we're done for today. Yeah. Any other last minute questions or?
Are you against counting carbs?
I'm not against it. No, I'm not. I think for individuals who are on oral medications, my opinion is that if we can change habits and behaviors, we probably don't have to necessarily carb count. But for people taking insulin, yes, it is necessary to carb count. Yeah. Mm-hmm. Great question. Anybody else? Yes.
What's your opinion on the almond flour and coconut flour and all of that?
Okay, so the question is about alternative flours. I'm going to get in the habit of that. So she asked about like flour versus coconut flour versus almond flour. I don't really have anything against any of those. I think you could definitely use them. That would be considered a whole food. So no harm in trying those out. I think they were really created to meet the market for those trying to avoid gluten. So that's kind of where that all came. But there's probably nothing inherently wrong with using them. Yeah.
I was wondering, what can we do with like Atkins or keto or Weight Watchers? Are any of those worth messing with?
Gosh, that is a loaded question. Do you guys want me to answer that? Wait, we're so the question is what's kind of I think the question is, what is the outcome difference, or which one is the superior diet to follow? Atkins versus Weight Watchers versus South Beach versus, or use anything specific? Do you guys want me to answer that question? Yes? Okay, awesome. That's a great question. All right, it is going to add 5 minutes. Are y'all okay with that? 5 minutes? Okay. 2? All right, challenge accepted. Okay. So, 10? Oh, okay, he said 10. I thought he said 2. I was like, oh, well, I better hurry. Okay, so losing weight's really challenging, right? Or no, hold on. Can we lose weight fairly easily? Can people generally lose weight? Generally, yes. But the problem is keeping it off. Like, how many times have people lost weight and they've been able to do that, but then it's come right back on? So really, the weight maintenance is the issue. To specifically answer your question, I have to refer you to a study that looks at this question. And it's called the National Weight Control Registry. You guys can look it up if you want to. National Weight Control Registry. So this is another independent study. And what these researchers are doing are they're basically looking at people who have lost weight and maintained it. So they did both. They lost weight and maintained it. And for most individuals, they've lost like 30 pounds and kept it off for on average, they've kept it off for about 5 years. That's not the criteria to be part of the study. That's just what on average people have done. So basically, you look at that and you're like, well, that's great. How did you do that, right? So that's what these researchers are looking at. They're basically saying, what did you do? And so what they found, this has like over 10,000 people in it, they found that not one single person lost weight the same way. So that's one. Number one, we're all unique snowflakes, and some things are going to work really great for some people, and other things are not going to work as good for some people. Going back to your question, we can see that. So if we have Weight Watchers versus South Beach versus whatever have you, we have this thing where people are generally scattered as successful, or they have different degrees of success. But then what happens? We also have what's called these outliers. These people who are like highly, highly, highly successful, and then people who are really not successful at all. So the point is that all of these diets worked. It's just a matter of which one makes the most sense for you. Did that kind of answer your question? Sure. You can try it as long as as long as it's whole food, and you're like cooking at home. That is always a good approach. Yeah. So like honestly, my philosophy is that as long as it's a whole food and you're consuming it at home and cooking it at home, it's inherently a good approach. Yeah. Yeah. So.
Somebody in Phillipsburg was asking what you think about ice drinks.
Ice.
Sparkling.
Oh, the sparkling water. Yeah, so I don't have anything against sparkling water. In fact, if you're trying to get off soda or diet soda, that's probably the next best choice. The gold standard, so that's a gradation question too, actually. So the gold standard is what? Thank you. Um, what's the next thing after that? I don't know. Homemade tea, coffee, pure black coffee, of course. Yeah, that's the only way to do it. Or you could have like unsweet tea. Like those are all great choices. And sparkling water basically falls in that realm. So there's really nothing wrong with it as far as we know right now, anyway. So, yeah, great question.
Asking about the ice drinks specifically, maybe they drink them, but
Are the ice drinks?
they're they're flavored. They have
Oh,
antioxidants.
I'm going to accept
Yeah, go
cookies.
ahead.
I want to look at the ingredients. View nutrition facts. Sorry, thank you. Yeah, I can't say I'm impressed with this product. So I wouldn't call this, I would call this as designer food as well. Yeah.
On the ice, you might just make that as so let the people in
So the the product, sparkling ice, I would call that a designer food as well. I wish we could pull up a picture of it tomorrow or something. Yeah. Yeah, so homework assignment for you guys. If you want, feel free to grab something from your, your kitchen. Bring in a food label tomorrow, and we can talk about it before we get started with the second session. Does that sound good? All right, awesome. Meeting adjourned for today. Yeah.
Can you also say, and specifically to the people in Phillipsburg, you guys can send
Pictures.
pictures to Christy.
Okay, if you guys, Phillipsburg, if you guys want to send pictures of your food and food labels from home and bring them and take a picture and send it to Christy, we can discuss any questions at that point. Okay? Okay, awesome. All right. I would call it a designer food. There's a lot of unknown things in there, or juices or extracts, and really, shoot. Yeah. It would be a step up. I would say it would be a step above than like diet soda. So that's probably better than diet soda. So, yeah. Cool.
Kind of along that line, I sometimes put, I asked a nurse about like Crystal Light putting it in
Yes.
water, and she said, what's the sweetener in it? You know, what
Yes.
sweetener do they use?
Yes.